On behalf of CCDSI Bihar and Jharkhand Chapter, I welcome you all in our monthly e-CME program. I would especially like to welcome our founder president, Dr. A.N. Rai, and president-elect, Dr. A.K. Virmani. With same spirit and enthusiasm, I would like to welcome our chairpersons and guest speakers who have kindly consented to share their experiences with all of us. Honestly speaking, this meeting was planned a couple of months ago in physical mode to be held at Jamshedpur with the help of Dr. A.K. Virmani as convener of this meeting. But then, due to third wave of corona pandemic, we were compelled to convert it into a virtual CME. And the rest you all know. Dr. Virmani is still there as convener of this meeting. And in fact, he has played a key role in organizing the speakers and everything else. Before I request Dr. Virmani for his introductory remarks, there is a small information which I would like to share with all of you. Due to some unavoidable reason, there is slight change in the schedule. Now we will begin with the second session. And the first speaker will be Dr. Aravinda Jagdeesha, followed by Madam Chhabra. Chairpersons will be the same, Dr. R. Choudhary and Dr. Naresh Singhal. So with this change, the second session will be as usual. The first session will become the second session. So with these few words, I request Dr. A.K. Virmani, the convener of this meeting, and the president-elect of CCDSI for his introductory remarks. Dr. Virmani, please.
Thank you, Dr. Lohani, for giving me this wonderful opportunity of organizing this program. I really wish it could have been physical and not virtual, but unfortunately we had to make it virtual, as you rightly said. But then, you know, as you requested me, I organized the speakers, and we are going to have two sessions with speakers who are of both national and international repute. And the second, we have four speakers actually. Yeah. In the first session, we'll have Dr. Aravinda Jagdeesha, who is from the director and the MD of Aravinda Institute of Diabetes in Bengaluru, and he'll be talking on sugar in blood and fat in liver, who's the culprit. And then we have Dr. Meena Chhabra, who is the president of the IPF Innovative Physicians Forum in Delhi, which is started in Delhi, but that is also a national body. And she will be talking on Bikini Medicine. Can I request everybody to mute themselves, please? Yeah. And Dr. Meena Chhabra will be talking on a very relevant topic today. What is Bikini Medicine, and is it really relevant today? And then followed by that, we'll have two another good speakers. Again, Dr. J.K. Sharma from Delhi, who is the General Secretary of the Innovative Physicians Forum. He will tell us something about the management of painful diabetic neuropathy. And then Dr. Bijay Patni, who is the founder member of the Diabetes Research and Welfare Association, Calcutta. He will be talking about the ADA 2022, what is new in the ADA guidelines. So to start with the first session, I will request Dr. R. Choudhary and Dr. N.C. Singhal to kindly chair the session. Over to you, Dr. Choudhary, sir. Please unmute yourself.
Thank you, Dr. Virmani. I would like to thank Dr. Lohani and Dr. Abhishek for providing me this opportunity to chair this session. My co-chairperson is Dr. Naresh Singhal. I would request Dr. Naresh Singhal to introduce the speaker and introduce the subject. Dr. Singhal.
Yes, sir. Good evening, everybody. I hope I'm audible.
Yes, you are audible.
Yes. Hello. So I have great pleasure in introducing Dr. Professor Aravinda Jagdeesha. He is highly qualified person. He is in internal medicine. He is MRCP in London, UK, FRCP Edinburgh, FRCP London, and FRCP Glasgow. He is a proprietor and chief diabetologist of Dr. Aravinda Diabetes Center in Bangalore. His vast experience of working in various hospitals in UK, especially in the field of and energy. One of the few with MRCP London with triple FRCP Edinburgh, London, and Glasgow. He has several awards. He has Times of India Healthcare Award in Diabetes and Endocrinology in 2018. His Bengalore's highest civilian award, Nada Prabhu Kempegowda Award, for his work in the field of diabetes in 2018. He has received the Diabetes Awareness Initiative Award in Diabetes India conference held in New Delhi in 2017. He has over 75 conference presentations, 30 publications, and is involved in clinical trials conducted by Dr. Arvind's Diabetic Center. He is an eminent speaker of both national and international level conferences and webinars. Most recent one was in International Diabetes Federation conference in Busan, South Korea, and is also part of various organizing committees. He was the president of the RSSDI Karnataka chapter in 2018-19. Over to you, sir, for your presentation.
Thank you, sir, Dr. Nareshji, for the nice word, nice introduction. Thank you, Dr. Choudhary ji, for the nice words. So first of all, I'll like to thank Dr. Anil Virmani ji, Dr. Lohani ji, and Dr. Abhishek for making me a part of this conference. I'll be sharing my slides now. Are you able to see my slides?
Yes.
Yes.
Yeah. So this is an interesting topic. Actually, Dr. Anil Virmani sir asked me to speak on this particular topic. The title looks very interesting, isn't it? The sugar in blood and fat in liver, who is the culprit? So I thought it was a totally new subject, a new concept. Actually, it's a new concept because in my conference there was a twin cycle hypothesis which Dr. Anil Kumar Virmani has spoken about. So in the same way, this is a different topic. There is a sugar in blood and fat in liver. So I went through so many articles regarding this and found it really interesting. So many new things we'll be learning today. I'm sure all of us will be discussing about this particular topic. First of all, greetings to all of you from Bangalore. So we know management of type 2 diabetes complexity becomes more challenging over time. You know, a diagnosis, treatment review, and older patients. So as the disease progresses, we need to address all this issue. There will be a clear guidance, that is at-risk screening, diagnosis, monitoring, and initial treatment. In the middle, the complications may arise like CVD, that is cardiovascular disease, chronic kidney disease, liver disease, adverse effect to treatment, and the need for treatment optimization. Ultimately, the quality of life becomes one of the most important consideration. We know these things, the basic things, that diabetes is associated with many complications. On the left-hand side, you can see the microvascular complications like all the brain and cerebral circulation, retinopathy, dental disease, nephropathy, erectile dysfunction, and diabetic neuropathy. On the other right hand side, you can see macrovascular complications like stroke, heart disease, liver disease, and peripheral vascular disease. The important point we are going to discuss today is about the liver disease. I think less of topics has been covered with regard to this, because most of the time the concentration will be on the heart, on the kidneys, on the eyes, on the nerves and all. But liver disease is the most of the conference will not be covered. So this is an interesting topic for sure. If you take these basics of liver, this is the anatomy and function of the liver, just to refresh ourselves. I'm sure all of us will be aware of this, but we need to refresh now and then. The liver has many functions, including bile synthesis, conversion of glucose to glycogen for storage, production of cholesterol, regulation of the blood clotting. It is important to assess liver function in patients with type 2 diabetes as it may affect the treatment option. So this is an important consideration. We should know where to check and what to do. Type 2 diabetes and liver dysfunction. You can see foreshadowing on the left-hand side, the liver disorders in type 2 diabetes is the commonest one. The 70% will have fatty liver disease. I'm sure in most of the diabetic patient, if you do an ultrasound abdomen, they'll be having fatty liver. So most of the time patient will question you, doctor, what is this fatty liver? You say, oh no, fat accumulation in the liver, little bit is there. You control your cholesterol level, you control dieting, you do regular exercise, you will be all right. This is what we are telling as of now. So 70% of our diabetic patients will have fatty liver disease. The rest will have, some people will have elevated liver enzyme, and some people will go to cirrhosis. From the fatty liver disease, why it is important is, this may lead to poorly controlled diabetes, leads to severe insulin resistant, and there will be high insulin requirements. So non-alcoholic fatty liver disease often coexists with the type 2 diabetes. The presence of type 2 diabetes in patients with NAFLD is a risk factor for progression to non-alcoholic steatohepatitis. What is that? It is a severe form of NAFLD that can progress to liver fibrosis, cirrhosis, and hepatocellular cancer. Hepatostatitis and NAFLD. This is the two terminologies, same terminologies. What is it? It is defined as a fat deposition in the liver that exceeds, this is an important word, that exceeds 5% of the total weight of the liver, 5% of the total weight of the liver, or with more than 5% of hepatocytes containing fat deposit under light microscopic examination. The condition is also known as non-alcoholic fatty liver disease. So hepatosteatosis and NAFLD are the same terminologies. Next one is the non-alcoholic steatohepatitis, that is NASH. What is that? When there is an inflammation and liver damage, you call it as NASH. In general population, prevalence of NAFLD and NASH is approximately 20 and 3% respectively. The prevalence of NAFLD is high in conditions associated with insulin resistance, such as obesity, type 2 diabetes, dyslipidemia, and the metabolic syndrome. You can see here the prevalence of NAFLD. In diabetes, it is 50 to 75%, obesity 50 to 90%, hyperlipid, that is dyslipidemia, it is 20 to 80%. When you take the distribution of NAFLD by racial or ethnic region, on the left-hand side in the study population, on the right-hand side, you can see the US population. Both NAFLD is more common in Caucasian. Now you can see the yellow one, that is the Caucasian. On the left-hand side as well as the right-hand side, it is more common in Caucasian. And when it comes to Asians, it is around 16 to 17%. So NAFLD is seen in Asian patients. When it comes to gender, we can see in the Caucasians, the female is the preponderance. That is, NAFLD is seen more in female. Interesting thing is, when it's in Asians, you can see on the extreme right-hand side, NAFLD is more common in males. So Caucasian, it is common in females. In Asians, NFLD is more common in males. So pathogenesis is a two-hit paradigm. The first hit is that excess accumulation. The second hit is the intrahepatic oxidative stress, lipid peroxidation, TNF-alpha, and cytokine cascade. This is the proposed histologic spectrum of NAFLD. The first one is starting from the left-hand side. The stage 1 is the fat accumulation. Stage 2 is the fat plus inflammation. Stage 3 is the fat inflammation and ballooning degeneration. Stage 4, that is the cirrhosis, we can see fat ballooning, degeneration, fibrosis, plus or minus Mallory bodies. So this is the slide looks busy, but this is how the pathogenesis of NASH and various aspects of the liver takes place. The first is the insulin resistance, leading on to steatosis, leading on to steatohepatitis, finally to the last stage of failure, that is the cirrhosis. This is an important slide where my whole talk is based on, today's talk is based on, that is the twin cycle hypothesis. So you can start from the left-hand side top, that is the positive energy balance that will lead to increased liver fat. Increased liver fat leads to resistance to insulin, that is suppression of glucose production. What does it do? It increases the plasma glucose and increases the basal insulin, and the liver cycle closes there with the pre-existing muscle resistance, and ultimately the cycle continues. This is the liver cycle. When it comes to increased liver fat, what happens here is it increases the VLDL, that is triacylglycerol. This will increase the highlight triacylglycerol, leads to beta cell dedifferentiation. This is now the pancreatic cycles takes place. Leads to decreased insulin response to ingested glucose. That leads to increased postprandial glucose level and increased basal cell insulin secretion. This is where the liver cycle and the pancreas cycle, the two cycle merge together and what we call it as twin cycle hypothesis. I'll tell you in next few slides regarding the bit details about the twin cycle hypothesis. Professor Roy Taylor from UK said gave an interesting and very important statement. When fat cannot be safely stored under the skin, it is then stored inside the liver and overspills to the rest of the body, including the pancreas. This clogs up the pancreas, switching of the genes, direct how insulin should be effectively be produced, and this causes type 2 diabetes. This is an important statement saying how the type 2 diabetes can become from the fat. That is what we are discussing, where sugar in the blood or fat in the liver, which is the culprit. So this is a statement from Professor Roy Taylor. So twin cycle hypothesis was published in 2008, postulated that hepatic insulin resistance and dysfunction rather than the death of beta cell determine the diabetic onset. See this important hypothesis. So the hepatic insulin resistant and dysfunction is more important than the death of the beta cells, which will determine the diabetes onset. The next point, the several studies were carried out to test this hypothesis, and all are demonstrated that the chronic excess calorie intake and ectopic fat accumulation within the liver and pancreas are fundamental to the development of this disease. The direct trial has clearly demonstrated that remission of type 2 diabetes is feasible and durable by direct weight loss in the routine primary care environment. Decrease in both hepatic and intrapancreatic fat is the prerequisite for the diabetic remission, provided that beta cell ability to recover after removal of this metabolic burden is retained. This is an important point of twin cycle hypothesis, which gives a new insight to saying that liver fat plays an important role in the development of pre-diabetes as well as type 2 diabetes. So diet and persistence can definitely reverse the diabetes. If you take the clinical feature of non-alcoholic NASH, that is non-alcoholic steatohepatitis, the clinical feature is vague: fatigue, malaise, right upper quadrant discomfort. It is variable and it is mostly, sometimes it may not be there. Signs: hepatomegaly may be seen. Splenomegaly is seen in some patient. Portal hypertension is unusual. On the right hand side, you can see the lab values where there will be increased AST, ALT, and there will be increased alkaline phosphatase, GG and GGT, increased cholesterol level, triglyceride levels, increased level of glucose, viral markers will be there, autoantibodies, iron studies will be abnormal. When you do the ultrasound abdomen, you will find the fatty liver. So insulin resistance is the key pathogenic factor for the development of both type 2 diabetes and NAFLD. The risk of type 2 diabetes increases by 5-fold in these patients as a result of insulin resistance in hepatic tissue. This is a research article where they've seen association between the fatty liver index and the risk of type 2 diabetes in the EPIC Potsdam study. The risk of developing type 2 diabetes can be modified with improvement in NAFLD. This is an interesting slide. High liver fat leads to high diabetes, cardiovascular risk, and nephropathy risk. You can see, you can concentrate on the third person here, where it says as high risk, low insulin secretion, high genetic risk that person has got, leads to high diabetes risk, high cardiovascular risk, and nephropathy risk. Now coming to the fifth one, that is what you are seeing in the middle one. It is a cluster 5. It is a high risk where you can see high liver fat and insulin resistance. This leads to high diabetic risk, high cardiovascular risk, high nephropathy risk, and higher mortality. Next one is the cluster 6. That is the high risk. You can see on the extreme right there, you can see the 6th person there. It has got a high visceral fat and high renal sinus fat. Interesting thing is, you can see here, relatively low risk of diabetes, high risk of nephropathy, and high mortality. So we always think visceral fat is more important and more risk for diabetes, nephropathy, and higher mortality. But it has got a risk. But however, this slide shows cluster 5, that is person having high liver fat and insulin risk, insulin resistance, is having a high diabetic, cardiovascular, nephropathy risk, as well as higher mortality. This is an interesting slide presented by Robert Wagner et al. In Nature Medicine 2 years back in 2020. One interesting thing is not to forget is lean or non-alcoholic fatty liver disease. We should do not forget diabetes. So what does it says is patients with lean NAFLD and a medium waist circumference have greater odds for incident diabetes than patients with obese NAFLD and a medium waist circumference as well. So in this study, you can see here, non-alcoholic fatty liver disease is independently associated with an increased incidence of cardiovascular events in type 2 diabetes. So cardiovascular events in NAFLD are increased by 1.87-fold in the presence of type 2 diabetes. Another article shows NAFLD is also known to increase microvascular complications of diabetes, such as chronic kidney disease and retinopathy. So see the importance of association between diabetes as well as NAFLD. So you can, in this slide, they've seen the long-term follow-up of patients with NAFLD and elevated liver enzyme. Sometimes you will feel when you see in your patient routinely, when you ask for a liver function test, you will see an abdominally elevated liver enzyme, that is SGOT and SGPT. It may be 1.5 times, 2 times, or 3 times like that. So what to do at that point of time? You just think of it, you think of medication, you think of associated problem, all those things you'll think of. But in this study, you can see here, on the bottom, you can see person with when ultrasound is done, when the person with no steatosis the risk of him developing type 2 diabetes is less. When compared to the right-hand side, you can see extreme right, progression from mild to moderate severe NAFLD, if the person has progressed, his risk of developing diabetes and complications is more. Liver fat content and risk of diabetes. You can see in this study, stepwise increased amount of liver fat expressed as percentage of steatoria area in liver biopsy increases diabetic risk as well as mortality. So these are the various, this slide look busy, but these are the various epidemiological evidence linking NAFLD to the risk of new onset diabetes. There is a Japanese study, there is a Chinese study, there is a South Korean study where they have seen there is a link between NAFLD and diabetes. This is an interesting slide showing the putative biological mechanism by which NAFLD contributes to the diabetes development. You can see starting on from the left-hand side to the right-hand side, the various mechanism involved for the contribution of diabetes development. So now coming to an interesting aspect is the management of diabetes in hepatic impairment. We know we do the transabdominal ultrasound. It is a sensitive, non-invasive method for detecting NAFLD. However, diagnostic criteria are highly operator dependent and non-standardized. The second one is the spleen minus liver attenuation difference derived from CT shows a good correlation with pathology of hepatostatitis. So this is an interesting algorithm for the management of NAFLD. It looks busy, but you can take a snapshot. It gives if a person's AST and ALT, if it is elevated, you can see on the right hand side, you should do the liver ultrasound. If it is abnormal, you can refer to the hepatology referral can be done, or you can use clinical models, biomarkers, and alternative tests. In extreme cases, you can consider biopsy as well. So this is an interesting slide. You can keep it in your clinic so that it will be useful whenever the patient with abnormal enzymes comes, because we know there are so many causes for elevated AST and ALT. So when you think of NAFLD, you see abnormal AST, ALT, and there is a fatty liver in this ultrasound abdomen. So how to proceed? We should be knowing about this. So ultimately, if you see, you to diagnose NASH, once you diagnose NASH, lifestyle intervention, anyway, our diabetic patients would have done, then we can consider of pharmacological therapy as well. Type 2 diabetic medication in patients with hepatic impairment. This is an interesting aspect. We always discuss more about person having heart disease, person having renal disease. What about the person having hepatic impairment? Which drug to use, which not to use, which is recommended? All these things has to be known today. So the management of diabetes in patients with liver impairment may be complicated by liver-related alterations in drug metabolism, consideration around drug-to-drug metabolism, possible hepatotoxicity. The patients with evidence of liver failure, example, ascites, coagulopathy, or encephalopathy, are at risk of altered drug metabolism. In addition, patients with the decompensated liver disease may have an increased susceptibility to hypoglycemia and require careful monitoring. The choice of type 2 diabetic medication and or dosing may require optimization with respect to liver function. So the treatment of diabetes of cirrhotic patient has particular characteristics that make it different from type 2 diabetes without liver disease. You know that about half of the patients have malnutrition. When clinical diabetes is diagnosed, the patient has advanced liver disease. Most of the oral hypoglycemic agents are metabolized in liver. Patients often have episodes of hypoglycemia. So first thing is lifestyle modification. The initial treatment of patients suffering from mild to moderate hyperglycemia and compensated liver disease may be lifestyle change, since at this stage, the insulin resistance is the dominant factor. Lifestyle modification is the baseline treatment for any disease. So this may be compromised by poor nutritional status and general health. More than 50% of the patients with severe liver disease are malnourished. Next point, low glycemic, low calorie diets with weight loss of 1 to 2 kgs per week seem very reasonable. Physical exercise which improves insulin resistance may not be an appropriate measure in patients with active liver disease. Next comes the pharmacological therapy. While there are theoretical concerns about altered drug metabolism and hepatotoxicity, only patients with evidence of liver failure, such as ascites, coagulopathy, or encephalopathy, have altered drug metabolism. Now coming to the drugs, pharmacological drugs. One is the metformin, very important thing. Metformin may be particularly useful in obese patients in whom it may cause mild weight loss. So the second point is very, very important. It is relatively contraindicated in patients with advanced liver disease or in drinkers because it may predispose to lactic acidosis. Third point, metformin has not been reported to cause hepatotoxicity and has shown some benefits in patients with NAFLD. So metformin role is mixed. Means it may be used, may not be used in initial stages. Like that, the various studies have been demonstrated. However, we need to be very cautious in using metformin in advanced liver disease. Next comes the insulin secretagogues. Sulfonylureas are generally safe in patients with liver disease, but may not overcome the insulin resistance and defects in the insulin secretion seen in patients with coexistent alcohol liver disease and pancreatic damage. Sulfonylureas with short half-life like glipizide are preferred. Patients with decompensated cirrhosis may have a reduced ability to contract hypoglycemia, and thus the response to therapy should be monitored closely. Next is the glitazone. Yes, we know that it is currently recommended that serum ALT levels be evaluated before the initiation of pioglitazone therapy, and that therapy not be initiated if there is an active evidence of active liver disease or serum ALT level more than 2.5 times. It may be useful because they enhance insulin sensitivity underlying defect in the NAFLD. There was a potential hepatotoxicity with the troglitazone. However, this was not seen with the pioglitazone. Next is the insulin. Insulin treatment is frequently required in patients with diabetes and liver disease. Insulin requirements, however, may vary. In patients with decompensated liver disease, the requirement may be decreased due to the reduced capacity for gluconeogenesis and reduced hepatic breakdown of insulin. However, patients with impaired hepatic function may have an increased need for insulin due to insulin resistance. In patients with hepatic encephalopathy who require high carbohydrate diets, resulting in postprandial hyperglycemia, rapid-acting insulin analogs may be particularly useful. This is an important slide which gives you a gist of pharmacological use of oral anti-diabetic drugs in persons having hepatic dysfunction. On the left-hand side, you can see the various stages. There is mild hepatic impairment, middle one is the moderate hepatic impairment, the bottom one is the severe hepatic impairment. This is from the British National Formulary. You can see the metformin is contraindicated in all the stages of hepatic impairment. Sulfonylureas, definitely you can use glimepiride, gliclazide, glipizide as well. However, it is contraindicated in severe hepatic impairment. Acarbose, accepted in mild to moderate hepatic impairment, contraindicated in severe hepatic impairment. Next, you come to meglitinides. Natiglinide is allowed in mild hepatic impairment. Pioglitazone is not allowed in any stages of the liver in hepatic impairment. DPP-4 inhibitors, we can see.
Dr. Aravinda, you have 2 minutes.
Yes, yeah, I'm finishing with last two sets. DPP-4 inhibitor, you can see that most of the gliptins are allowed in hepatic impairment. Among the SGLT2 inhibitors, dapagliflozin, you can use comfortability in mild to moderate hepatic impairment. So pharmacological impairment therapy of NAFLD. Now what we discussed was the diabetes. we are thinking of NAFLD, the various drugs have been studied with NAFLD, like gemfibrozil, vitamin E, metformin, silymarin, pioglitazone, atorvastatin, all with a limited, short study with limited experience. So they have studied as well of ursodeoxycholic acid as well in the management of NAFLD. So oxidative stress plays an important role in NAFLD. There is the role of use of antioxidant in the management of NAFLD. Vitamin E role is bit controversial. Some studies are showing benefit. Long-term studies are not showing that much. There is an interesting article to show the benefit of pentoxifylline in the management of NAFLD. This is the gist of the, I'll be finishing in next couple of 1 or 2 slides. This is the gist of the current pharmacological options. You can, if you take a snapshot, you can, it will be very useful. So ladies and gentlemen, take home message from my today's talk is, for many years, it was believed that hyperglycemia of diabetes contributes to fatty liver disorder. Recent research has proved that fat in liver increases the risk of diabetes. Liver fat in pre-diabetic individuals are at elevated risk of end organ damage. Liver fat increases in presence of hyperglycemia, increasing the risk of complications in diabetes than the hyperglycemia alone. Liver fat is also associated with high mortality rate among the diabetic patient. So ladies and gentlemen, sugar in blood or fat in liver, who's the culprit? The decision has to be made today. Of course, the culprit is fat in the liver. Thank you for your patience hearing. If you have any questions, we can discuss.
Thank you very much, sir, for your very lucid presentation. With the paucity of time, I don't know, we can have 1 or 2 questions.
One question.
Yeah, one question here, sir. Dr. Aravinda, a wonderful talk. Now, in fact, it's not one question, it's 2 questions. The first question is, in the wonderful algorithm you showed, where is the place of FibroScan? And number 2, what is your opinion regarding the role of saroglitazole in the treatment of NAFLD?
Yeah, that is an interesting question, sir. First one is FibroScan. Yes, definitely it has got a role in diagnosis of NAFLD as well as NASH. There is a lot of conflicting studies about the use of FibroScan in the management of NAFLD, but in that algorithm it has not been included. Maybe we'll be waiting for the newer algorithm this year where the FibroScan may be bought. Regarding the saroglitazole, yes, that is an important drug. It's an Indian molecule. There are few studies which is then showing the benefit. We need furthermore studies to document and widely accepted. In my last the few slides, I showed various drugs to be used in the management of NAFLD. One of the drug is saroglitazole. But however, how it has been marketed in India, it may not be true in abroad as well, because we need long-term study, long-term safety data regarding the saroglitazole. Till then, you can use with a very cautious way.
Thank you, Dr. Aravinda.
Dr. Arvind, sir, just 1 minute. There is a very...
No, sir, please. We cannot exceed. We are running short of time.
Okay.
So, Dr. Singhal, please conclude.
Yes, sir. So this was just a very wonderful talk as far as the fatty liver and diabetes is concerned. And we know that the fatty liver is the big culprit because it can lead to cirrhosis ultimately. So it requires treatment from the very beginning. Now there is a lot of controversy regarding to treat fatty liver with a normal enzyme or not. So some say that do a FibroScan, as mentioned by Dr. Virmani, that if the FibroScan is abnormal, then treatment is a must. The enzymes may be normal in such cases. So, gentlemen, I think we hand you over to Professor Choudhary for the second talk.
Thank you, Dr. Singhal.
Thank you, sir. Thank you for making
one
me a
line
part of
comment.
this.
It's a two-way pathophysiological condition. Fatty liver or fat in liver can cause diabetes mellitus, and diabetes mellitus can cause fat in the liver. Thank you, Dr. Aravinda, for your brilliant talk.
Thank you,
Now,
sir.
the second talk is Bikini Medicine. Is it relevant today? And we have a speaker, Dr. Meena Chhabra. She is senior consultant and diabetologist in Sir Gangaram Hospital. She was chairman RSSDI Delhi chapter in 2020 and 21, and she is chairman Innovative Physician Forum. It seems new, Bikini Medicine, but it is not new. We all know what is Bikini, and this medicine is related to the parts which is covered by the Bikini, means breast and reproductive system of the female.
Here's what I found.
The initial concept of Bikini medicine was that the physicians used to examine the breast and reproductive system of the female, and the rest of the part of the patients were not examined. And for that we have Dr. Meena Chhabra, and I will request Dr. Meena Chhabra to present her talk, Bikini Medicine, is it relevant today? Dr. Chhabra, please. Unmute yourself, Dr. Chhabra.
Thank you, Chairperson, sir, and thank you, Dr. Virmani, for inviting me for this interesting talk called Is Bikini Medicine Relevant? And at the end of the talk, I'm going to say very loudly, not at all. And I'm sure all of you will repeat with me, no, not relevant anymore. So thank you so much, and give me permission to share my screen. Okay. So my screen is visible?
Yes.
Yeah. So first thing is that I would like to say that gender and sex are two different things. Sex means biology, a male and a female, while gender is a lot of other things. The role of the two genders may be different. And I'm going to talk about health disparity. This is a very interesting slide. What is health disparity? And when you read this, health disparity has been defined by the WHO as the difference in healthcare received by different groups of people that is unnecessary and avoidable. It is unjust and prejudiced. The existence of health disparity implies that health equity does not exist in many parts of the world. What is health equity? Equity in health refers to the situation whereby every individual, whether rich or poor, whether living in any part of the world, whether male or female, has a fair opportunity to attain their full health potential. So in the next slide, I'll tell you that why I'm talking about health disparity, because in spite of living in a metropolitan city like Delhi, I have observed health disparity between the two genders. Therefore, I like to reiterate what the chairperson sir told you, that the term Bikini medicine means that the treatment of women focuses on the breast and reproductive organs rather than looking at the body as a whole. In the late 1990s, the medical establishments recognized the problem with Bikini medicine. Outdated idea that men and women should be cared for similarly. Mistaken belief that a woman's health differs from men's health only in the parts of the body that a bikini could cover. Research has totally debunked this theory. Bikini view is a very myopic view of medicine. Bikini view versus the complete woman. What is it? Breast health and reproductive health is Bikini medicine. It is versus mental health, cardiovascular health, digestive health, sexual health, breast health, yes, bone health, and reproductive health. So I think all my colleagues will agree that Bikini view is not viewing the complete women. Now, I will, Dr. Virmani had requested me to present a case, and I'm so sorry. And this is Mrs. Madhu. She's a 58-year-old female. She was a type 2 diabetic. She was following up with me for 6 to 7 years, and she reported to the emergency in Delhi in a popular government hospital with chest pain and retrosternal burning. Doctors, I will show you all the evidence that no ECG was done. She was prescribed PPI for gas and sent home. Pain was severe. Patient was restless and she started crying, and the attendants took her to the emergency again. She was given an anxiolytic and sent home. She reported to me next morning on Monday when the pain had subsided. And on investigations, she had an acute anterior wall MI on ECG. She was sent to the ICU where I hospitalized her under the care of the cardiologist. Troponin I was high. We did it with the slide method. She had critical single vessel occlusion on angiography, a reduced LV systolic function, and an LV ejection fraction of 40% or even less, 38% on echo. You can here see the Gangaram prescription from the cardiologist, which says anterior wall MI with late presentation. Now, why was she treated so shabbily? I'll use the word why. And you can see the echo that we've lost the golden period and she has lost heart muscle. I wish to reiterate that there are gender inequalities, a lot of gender inequalities. 1 in 5 girls is married before turning 18. 1 in 4 girls is out of secondary school. Over 800 women and girls die during childbirth. The total number of women and girls subjected to the harmful practice of female genital mutilation and child marriage is still very high. The total number of women with an unmet need for contraception is growing, and half the women in a low mid-income country have no decision-making power over their own bodies, and they don't decide whether how many children they want to have. So this is one aspect that I would like to highlight, that why are the slides not moving? Yeah. So here I come to a very interesting term. It's not equality that is needed alone. I am saying there is no equality, but I'm going on to say that equity is needed. If a man and a woman are treated equally, which doesn't happen, even then they cannot attain their full health potential. Why? Because equity means that if you need a different tool to identify different problems and address inequality. So it's equity which is important, not just equality. And here we are struggling with inequality. And justice can only happen if we address a woman's health with equity. Now, there is a gender bias in diagnosis. A 2018 literature review of 77 medical articles found gender bias in the patient-provider encounter regarding pain. Women with pain are always viewed as hysterical, emotional, complaining, not wanting to get better, and fabricating the pain. Women suffering with chronic pain are erroneously attributed, oh, they have a psychological problem rather than a somatic cause for their pain. The effect on pain medication studies have determined that women receive less effective pain relief, less opioid pain medication, more antidepressants, and more psychiatric referrals. There has been a gender bias in clinical trials because women were excluded from clinical trials. And the reason given was that they could be pregnant in between the trial, they were high risk. In 1993, the US FDA published guidelines for the study and evaluation of gender differences in the clinical evaluation of drugs, which recommended that women should be included in clinical trials to explore difference in the sexes, specifying that the population included in clinical trials should be indicative of the population to whom the drug would be prescribed. So you have a drug which is going, for example, you have a drug for type 2 diabetes. It will be written for both men and women. And why women are they are underrepresented in the trials. So this is a very interesting thing, that even in trials there's a gender bias. Now, doctors, there's a gender difference in biological consequences of illness. We know that men are more vulnerable to major life-threatening chronic diseases, including coronary artery disease, cancer, cerebrovascular disease, cirrhosis of the liver, and kidney disease. Women suffer more from chronic diseases like anemia, hypothyroidism, autoimmune diseases, colitis, arthritis. But the biological advantage of women, according to God, was related to their ability to bear children. But this biological advantage that the women has disappears if the woman has obesity, if the woman has diabetes. Then I'll go on to prove that this advantage that the woman had, the biological advantage, disappears. Now, what are the social consequences of health and illness? Definitely a gender difference. We all know, because men and women respond differently. Women may not even consult the doctor. Women talk to other women, their relatives, and tend to, eat medicines at home. Even in developing countries, men seek treatment more frequently, and women force their husbands to go to the doctors, while women themselves. I have several couples coming to my clinic where the woman has an HbA1c of 10 and a man has an HbA1c of 8, and she says, "Doctor, first see my husband. He's the breadwinning member of the family." They don't even want to address their health. Again, a very, very interesting syndrome called the Yentl Syndrome. I would like to give a little perspective because I'm grateful to Dr. Virmani for giving me this talk and opening my eyes, and my antenna are up. What is Yentl Syndrome? Now, Yentl was a movie in the 19th century, and in this movie, a Jewish girl had to dress up like a man because Jewish young girls were not allowed to study. So this was the New England Journal of Medicine editorial, which gave this name Yentl Syndrome, because they said that the women having heart disease or coronary artery disease have different symptoms than men having coronary artery disease. So we tend to not diagnose heart disease in women because of the Yentl syndrome, or this mindset that we don't even realize that men and women are different. This is possible because the coronaries in women may be smaller diameter. They have different symptoms. They may not report with the same chest pain that men report to. So Yentl syndrome is one such important syndrome, and which opens our eyes. Now I'll be discussing how women are different. Now regarding diabetes and pre-diabetes, if you see a 20-year-old man, a boy, adolescent, and a girl, you will see that the lifetime risk of developing diabetes is 64.6% in an adolescent girl as compared to 55.5% in an adolescent male. Coming to a 20-year-old with obesity, the girl has a lifetime risk of developing diabetes 86%, and the boy also has. 60-year-old, there's a lifetime risk of 27% for a man, while it is 37% for a woman. Again, coming to insulin secretion and sensitivity in men and women, we know that more women are obese as compared to men, and more women are abdominally obese as compared to men. So the possibility is that the women have the burden of metabolic syndrome longer. They have a greater waist-hip ratio, they have greater visceral adiposity, and therefore when they develop type 2 diabetes, they have already few years spent in metabolic syndrome with dyslipidemia and other risk factors, and therefore the coronary artery disease risk or atherosclerotic cardiovascular risk may be more in women. This shows the insulin secretion and sensitivity in men and women. And this is in patients with normal glucose tolerance. The insulin sensitivity is more in women, and insulin secretion is also more in women. But when the patient develops type 2 diabetes, this distinction is lost, and both men and women have an increase in insulin resistance. Women more insulin resistant than men. Now, this is a very interesting slide, doctors, and I must talk about epigenetics here. So what is epigenetics? Epigenetics means that environmental and behavioral factors affect gene expression. So we have multifold increase in type 2 diabetes and obesity. It's not because the genetic sequence has changed. It is because there have been changes or epigenetic changes. And what are these epigenetic changes? Like these are epigenetic modifications, like you can have DNA methylation, you can have histone, modification. What does this do? It plays an important role in pancreatic beta cell differentiation and maintenance of normal beta cell function. So because of epigenetic changes, you have increase in the incidence of obesity and type 2 diabetes. So you can see here that if a mother is diabetic and she has hyperglycemia, what happens? The unborn fetus is subjected to high blood sugar because sugar crosses the placenta, and the unborn fetus responds by increasing insulin secretion by the beta cells. And so it has been seen that both the male and the female offsprings of type 2 diabetic mothers, particularly mothers who have uncontrolled hyperglycemia, are born with a lowered beta cell mass. On top of that, if a female girl is a female fetus, she delivers later a female baby, then not just the beta cell mass, but because of hyperglycemia, there is increased insulin resistance. So a female child born to a type 2 diabetic mother will carry the legacy. And so this maternal hyperglycemia begets hyperglycemia in the female child, as greater risk in the male child as well, but greater insulin resistance in the female child. And if there's a male child, only he will become diabetic. But if it's a female child, she will carry or transfer the risk to the her own offsprings. Now you see, there is a lot of sex difference between the two. Increased impaired fasting glucose in men as compared to increased IGT in women. And we all know that IGT will convert to type 2 diabetes earlier than IFG does. Increase in incidence of diabetes in the male, more as compared to the women. But you'll also see that there are other differences. Women have greater cardiovascular disease incidence. They have greater incidence of polycystic ovarian disease. They also have gestational diabetes, which are all pre-diabetic condition and predispose her to development of type 2 diabetes. Now, again, obesity, if you see prevalence of generalized obesity, this was an ICMR in-depth collaborative study in 4 states, Tamil Nadu, Maharashtra, Jharkhand, and Chandigarh. Since we are talking to doctors from Jharkhand, you will see, and you'll be happy to see that in Jharkhand, obesity is not as high as, say, Chandigarh. So if you see Chandigarh, the green bar is the men and the blue bar is the women. 24.2% of the men are obese in Chandigarh as compared to 38.7% of women. And if you again see Chandigarh and abdominal obesity, 26% of men are abdominally obese, while 44.5%, almost half the population of women in Chandigarh, are abdominally obese. And my previous speaker, Dr. Aravinda, showed that obesity leads to increase in intra-liver fat, and then this spilling of intra-liver fat into the pancreas leads to pancreatic fat, leads to beta cell dysfunction, and leads to diabetes. Now, heart disease is the #1 killer of women. Yesterday was the World Heart Day, and this is the Go Red campaign by the American Heart Association, where all women physicians wore red. Even some of the males joined us. This says that we should not forget heart disease in the women, like my unfortunate case that I just told you. Now, this is very interesting data. 35% of all deaths in women worldwide are caused by cardiovascular disease. 275 million women were diagnosed with cardiovascular disease in 2019. 8.9 million women died from cardiovascular disease in 2019. Cardiovascular disease in women understudied because they're not in the trials, under-recognized. We always think women cannot die of heart disease. They can die of breast cancer. They can die of cancer of uterus. Then heart disease is underdiagnosed. It is undertreated. And we know that women were underrepresented in clinical trials. Now, risk factors. What are the sex-specific risk factors in women? Premature menopause, gestational diabetes, hypertensive disorders of pregnancy, a preterm delivery, polycystic ovarian syndrome, plus systemic inflammatory and autoimmune disorders. Of course, the established risk factors are obesity and diabetes, of course, blood pressure and dyslipidemia, and a sedentary lifestyle. What are unrecognized risk factors? Psychological risk factors. Women go through a lot of psychological stress, abuse, intimate partner violence, then socioeconomic deprivation, poor health literacy, and environmental risk factors. We must acknowledge the effect of these risk factors, because only then we can understand that women can also develop cardiovascular disease. Now, this is an 18-year prospective population-based study in Finnish subjects, and it concluded that diabetes without any evidence of heart disease, angina, or ischemic changes indicates a higher risk than prior evidence of CHD in non-diabetic. So vis-a-vis a diabetic patient, even if a non-diabetic has already had one heart attack, the diabetic is still more likely to develop heart disease. And again, heart attack alert says that symptoms in men and women can be different. In men, you will present with chest pain, classical angina, so that the doctor is aware, an ECG is done, Trop I is done, an echocardiography is done, wall motion abnormality is seen. Now, in women, there could be fatigue, there could be nausea, vomiting, there could be lightheadedness or dizziness, and she may not complain of chest pain, or she is diagnosed as atypical chest pain and sent home with a diagnosis of gas or sent home with a diagnosis of anxiety. So this is very important. Now, again, migration and cardiovascular risk factors. So you can see that once you migrate from rural to urban area, your risk of developing, of becoming sedentary is higher, your risk of eating a high-fat diet is higher, your increase in BMI is much more, you have more chance of developing hypertension and a greater chance of developing diabetes. Why does this happen? Because when you migrate from a rural area to an urban area, we are talking about spouses when they migrate, lesser workload. Because in a rural area, she has to go fetch water, which is not to be done because there's water. Then she has to grind the grains, probably all she doesn't have to do anything like that. So less social, less physical activity and more carbohydrate-rich diet is the culprit that leads to greater cardiovascular risk in people who have migrated from rural to urban areas. Again, this slide says that the relative risk of cardiovascular events in men and women with diabetes. We all know that premenopausal women have cardioprotection because of the estrogen, because of the hormones. But once a woman is diabetic, this cardioprotective effect of the hormones is lost, and you will see that the risk of developing a cardiovascular event, heart failure, coronary artery disease, myocardial infarction, and the cardiovascular mortality is all higher in women with diabetes as compared to men. Now, again, there is a sex difference in blood pressure associated with cardiovascular outcome. When we talk about blood pressure targets, we say the same target for men and women. But in this study, it was found that an increasing cardiovascular risk was observed beginning at lower thresholds of systolic blood pressure for women. So should we have different blood pressure targets for men and women? Yes, we should. And we have to address this. These findings could be related to difference in vascular anatomy and physiology. Example, we know that a smaller arterial diameter in women than men after normalizing for body size. So we have to do further studies to decide whether it's only the systolic blood pressure goal which should be lower in women, or is it also the diameter of the artery. So these are observations in women that GD in women, insulin resistant, overweight, this serves as an independent risk factor for progression to type 2 diabetes, and type 2 diabetic women are more prone to develop cardiovascular disease. Then again, when it comes to stroke, the American Stroke Association's acronym says FAST, face drooping, arm weakness, difficulty in speech, and time to call emergency. But women may experience non-specific symptoms like hiccups, nausea, chest pain, fatigue, shortness of breath, and a racing heart. Again, they have none. Why are women more prone to strokes? Probably pregnancy, preeclampsia, they may be on birth control pills, women have more migraine. So these are, again, women-only factors that may be responsible. Then what about bone health? Men achieve a higher, men achieve a higher peak bone mass as compared to the female. Then when there's a decreasing bone mass with age, women lose bone loss more than men, and this bone loss is even more if the woman has premature menopause. So we should address osteoporosis differently in men and women. Then the stress of caregiving. A woman now has to take care of not only her in-laws, but if she has aging parents, she has to even look after them. So the stress of caregiving, mental health and diabetes, depression is more common in women, and depression is more common in diabetic women as compared to men, and depression over the lifespan is more in women. So again, menopause and sleep issues, prevalence of hot flashes correlates with prevalence of insomnia, and Menopausal women spend significantly longer time awake at night and have lower sleep efficiency. Cancers, again, there are lots of cancers which we must address, and they are more in women and they are more undiagnosed. Cancers of the breast, cervix, ovary, lip and oral cavity, and colorectal. Sorry. Anemia, again, there's a steepest increase in anemia in a place like Punjab, where we think that food is adequate. But because of high carb intake, low intake of probably vegetables and iron-rich food, anemia again. So we have to address in men and women differentially. I'm not talking about autoimmune disease, again, more in women. This is a very interesting slide. In 2009, women were asked about their perception of the leading cause of death. So in America, this study was conducted in 2009, and 64.8% women said, yes, women have heart disease and knew. And imagine in 2019, only 43% women could identify heart disease or MI as the major killer, because probably there was greater noise about cancer and particularly about breast cancer. So more women in 2019 knew about cancer, more women in 2019 knew about breast cancer, but lesser women in 2000 knew that heart disease is the major killer. So considering the women's perspective, my question is, why don't women report early? Many things. One, will my husband spend enough money on me? Will I gain weight because of the medicines? Will the therapy cause side effects? If I take medication, will the therapy cause side effects so that I will not be able to take care of my family? And another important issue is, if I have hypothyroidism, for example, or if I have impaired glucose tolerance, should I let my future in-laws and future husband know? Will I be able to get married? What if my health affects my pregnancy? These are various questions that have to be addressed. So doctors, I like to reiterate that Bikini Medicine is a big no. My patient whom I say, poor patient who was so badly treated, she did not even get an ECG. She did not get a 100-rupee test, or probably a test which could have taken just 5 minutes in a government hospital. And she suffered from a massive MI and now in my hospital, the angiography was done, but angioplasty was not possible because she already had an ejection of 38%. So to conclude my talk, I'll say that Bikini Medicine is a very myopic view of women's health. Bikini Medicine just focuses on reproductive health and health of the breast, forgetting mental health, forgetting cardiovascular health, forgetting GI health, forgetting neurological health, and of course, not addressing mental health. Thank you.
Thank you, Dr. Chhabra, for your brilliant talk. Is Dr. J.K. Sharma is there?
Yes, sir. Good evening to all. I'm here.
We are very much happy to have you here. Do you have any comments, sir?
Me?
Yes.
So I have a comment. I would like to thank two people. I would like to thank Dr. J.K. Sharma for actually opening my eyes to this topic, because he shared slides on, and I've listened to him, and he shared slides on equality, equity, difference between sex and gender. Sex is just male, female, but gender is so much more. As a woman doctor, I still have more responsibilities, probably looking after the children or their school. And men have different kind of responsibilities. So I think I like to thank Dr. J.K. Sharma because he really, really opened my eyes. And then I would like to thank Dr. Usha Sriram, who's been really raising a lot of voice, even in national forums and international forums, that women and men's health has to be addressed differently. We have to keep our eyes open for identifying more women with obesity, more women with impaired glucose tolerance, with diabetes, and treat them better so that they don't land up with cardiovascular disease.
Yes, Dr. Sharma.
Yes. Dr. Meena, very prolific speaker, as we all have heard her just now, and I have been listening to her for number of years. She has covered the topic so well that many of us, we were not aware that this much is the medicine regarding the Bikini Medicine. There is much, much more than that. And I'm thankful to Dr. Virmani for giving her this very important topic. And she has really represented and she is taking she's the torch bearer for all female physicians in our fraternity and also of the male physicians. And thank you, Dr. Meena. Wonderful talk. I'm really thankful.
Thank you. Thank you.
I think I must congratulate Meena for you have done full justice to the topic I gave you, and I'm really proud today that the things that I wanted you have really brought out. I'd just like to add one thing, regarding cardiovascular disease. There is latest data from the American Heart Association, which has said that women are more likely to suffer from atypical chest pain. They're more likely to have non-specific EC changes, and on pathology, they're more likely to have MINOCA, that is myocardial infarction with non-obstructive coronary arteries and coronary artery dissections.
Syndrome X.
And this is something new which has come, which even I didn't know when I was going through the American Heart Association guidelines. This wonderful thing has come up. I think both the speakers have done a wonderful job, and we close this session. But before I go to the next session, I would request Professor Dr. A.N. Rai, our founder, to give his final comments on these two topics. Professor A.N. Rai, sir.
Yeah, thank you, Dr. Virmani. I think the first talk was really a very good talk by Dr. Aravinda, and it is always. I gave this topic to Dr. Hemsankar Sharma. That insulin resistance is the mother of this fatty liver is the mother of insulin resistance. So this was the very important topic, very well discussed, and early features of insulin resistance is fatty liver. So insulin resistance is the mother of fatty liver, and it is the genesis of diabetes, and he has very well explained. Second topic, Bikini Medicine. We all know that she has said, always females are differentiated, and reproductive organs they are care for reproductive organs, but they are human beings. There is no gender variety. They equally suffer from coronary artery disease, neurological disorder, mental disorders, GIT disorders. So they should be equally treated at par with the males. There should not be gender inequality. Thank you very much, Dr. Chhabra.
So in the last, I would like to say, whenever you receive a patient, examine in full.
Absolutely, sir.
And I have one little short question to Dr. Chhabra. What about the gender bias of the patient? A patient goes to the female patient goes to the female doctor. She avoids male doctor. What about that?
No, I think there is reverse gender bias. That when I remember, sir, I'd like to share an anecdote that when I was treating an MI, the old person said that I really find you nice, sister, but please don't treat me for MI. Please call her doctor. So yes, but doctor, I think in metro cities now, female physicians, particularly the geriatric patients, relate to us better, and the younger diabetic patients relate to us because we can explain diet and all. Yes, there's a gender bias. More male patients like to go to a male physician, but this gender bias is now disappearing in metros. I have almost 50% of my patients are males. But again, what I reiterate is that Dr. Virmani and Dr. J.K. Sharma, by bringing this topic, have opened our eyes that we have to treat. And it's not about equality. The word is equity. Because if we treat them equally, we'll give the same medicines to both of them. But no, a woman needs something different. Because I'll tell you, Dr. Sir, one thing, I'm taking time. I keep telling a woman to walk and a man to walk. The man goes for a walk, but my female diabetic cannot go for a walk. So all the males, because we say morning walk, and it's the morning when she has to make a tiffin for her children, send them to school, make a tiffin for everybody, look after the aging in-laws. So it's difficult for a woman to even walk. So I have seen all this. And yes, we have to talk about not just equality, but equity. She should be allowed to walk. And yes, women have to address, their own health issues. They have to come up to the doctors. Thank you so much.
Thank you, Dr. Chhabra. Now this session is closed. And now I hand over to Dr. Lohani for another session.
Thank you, sir, for the chairing this session. Both the speakers, Aravinda and Meena, have done a wonderful job. Now we'll
Thank you, sir. Thank you.
we'll go to the second session, and I request Dr. D.P. Khaita and Dr. S.C. Jha to please conduct this session.
Thanks, Dr. Virmani, the elect President Sri Desai, for imparting opportunity to us, both of us, for chairing the sessions. There are two eminent speakers today, Dr. J.K. Sharma from Delhi and Dr. Bijay Patni from Kolkata. All of us know them. I would like to, Dr. Jha, which chair would you like to chair? Which session would you like to chair? The first session or the next session?
As you direct me to, sir.
Okay. I think you chair the next session. I will chair the first.
Okay. Thank you, sir.
Okay, sir. Thank you. As introduction to Dr. J.K. Sharma, he is the Central Delhi Diabetes Center, New Delhi. He is the medical director of this center. And he is the visiting professor and faculty, Department of Medicine, Diabetology, Jain Medical College, KLE, Academy of Higher Education and Research in Karnataka. He was conferred academic activities par excellence. He was conferred DSc by HNBU Medical Education University in Jharkhand. He is the honorary professor of IMA headquarters. It's a very post of privilege. He is the fellow of the American College of Endocrinology, UJC. He is the fellow of all the 4 Royal College of Physicians, including London, Edinburgh, Glasgow, and Ireland. He is the international advisor, Royal College of Physicians of Edinburgh for North and Central India 2019 to 2024. Honorary GAPO, that means Global Association of Physicians of Indian Origin, and distinguished fellow. He is the president IMA Carol Bagh branch for 21 to 22. Vice President American College of Physicians India chapter 2021 to 24. He is the Vice President Geriatric Society of India. That's very good. DC member All India RSSDI National 2019-2022. Honorary Secretary RSSDI Delhi chapter during 2017 to 2024. Founder and Secretary of General Innovative Physicians Forum. Recipient of Lifetime Achievement Award 2018 from RSDI. It's a very is a academic oriented person with good repute. Without taking much time, I would like to request Dr. J.K. Sharma to start his topic, sir. Please.
Thank you very much, sir. I'm thankful to Dr. Virmani, Dr. Lohani, Dr. Abhishek, and chairpersons and the whole organizing committee of this wonderful webinar. Now, I would like to share my screen. Just a second. Sir, my screen is visible?
Yes, sir.
So, just a second. The topic given to me by Dr. Virmani is management of painful diabetic neuropathy. And after listening to these two very important talks, and they have been to the tune of something like a oration by Dr. Meena Chhabra, I would take you through this topic. Just a second. Just give me 1 second because my I'm getting little technical problems, so it will take me 1 minute.
In meantime, I would like to say that, are you okay, sir? Now we start?
So just give me 1 minute.
Yes, sir. In meantime, I would like to say that this painful diabetic neuropathy is a very common problem nowadays, occurring in at least 50% of the case of diabetic in due course of time, say 25 years of time. It is a very disturbing condition. The sufferer may recognize what a sort of disability in form of the pain he is possessing, he is having that. Myself being a diabetic patient, do recognize or do feel the disabling part of this painful neuropathy. Yes, sir. Doctor, please, doctor.
Yes, sir. So I come to the first. First slide.
Press on the arrow on the left.
Yes, sir. Yes. So my first slide is through a case study. As discussed with Dr. Virmani, this case is of type 1 diabetes, a young man of 29 years with 12 years duration of diabetes, complained of sudden onset of pain in both legs and feet. And at the clinic, he described the pain as an excruciating burning, squeezing sensation in his feet and legs, accompanied by cramps in his calf muscles. During the day, he is unable to wear shoes comfortably and experiences worsening pain when walking or bearing weight. At night, he is unable to tolerate even the touch of the blankets on his skin, and he has become exhausted from the pain and lack of sleep, complains of frequent episodes of diarrhea, and has lost more than 10% of his body weight over the preceding 3 months. We all know that uncontrolled diabetes is also a cause of weight loss. And nowadays we see that, and we advise that during the initial 6 years of diabetes diagnosis, if our obese patient loses 10 to 15% of his weight with controlled diabetes, there are chances that the diabetes may go into remission. We are not sure whether this will go into reversal or not, but remission is definite. And the second case which I'll take is 55-year-old male, bartender, married with 2 children, type 2 diabetes for 15 years duration. He has been treated with metformin 1 gram twice daily and gliclazide MR 60 milligram daily. Compliant with diet, he is a vegan, weight is constant, moderate alcohol intake, but occasionally there is excessive alcohol also, 12 cigarettes per day. He checks his blood sugar every morning, average is 135, and the HbA1c is 8.5%. And he has been referred to us by the GP. Such kind of patients we always see. And the reason for referral was complaining of burning pain in the soles of feet, especially at night when lying in bed, at times experienced lancinating, that is piercing and stabbing leg pain, paresthesia and numbness of the toes, sleep interrupted because of painful feet, felt depressed. And such kind of case study presents a challenging clinical situation every day to us. When we examined, the general examination revealed a middle-aged man with a ruddy complexion and spider nevi on his cheeks and nose, appeared anxious and mildly depressed, 76 kg weight, BMI 23, blood pressure 135/90, pulse 88, and regular but weak foot pulses and no bruise. Cardiovascular system examination clinically unremarkable, stress ECG limited by painful legs on exercise. Abdominal examination, central adiposity and tip of the liver palpated, feet healthy, but toenails showed evidence of onychoics, or that is the overgrowth or thickening, absent ankle reflexes, and impaired sensation to soft touch, pin prick, and the vibration sense. And the random blood sugar done at that time at 11 o'clock was 180 milligram %. CBC and hematological parameters, normal, renal functions, including electrolytes, normal, but I would like to mention that this patient had microalbuminuria. So liver function, abnormal and moderately raised ALT, AST, GGT, and AL. SDL cholesterol 0.8, LDL 1.8, TG 3.8 millimole per liter, HbA1c, as I told you, 8.5%, thyroid functions normal, low vitamin B12, 105 pmol per liters. The diabetic complications and comorbidities in this patient, we could find out there was background diabetic retinopathy, peripheral neuropathy, calf muscle claudication on walking more than 75 meters on the flat, suggesting peripheral vascular disease. There was microalbuminuria, hypertension, hypercholesterolemia, and moderately depressed and anxious personality. Treatment patient was taking paracetamol 2 to 4 hourly because of pain, aspirin 100 milligram per day, perindopril, simvastatin, metformin, and gliclazide. So this patient has all the complications of diabetes and uncontrolled diabetes with other comorbid conditions. Now, we all know that the chronic complications of diabetes, as has also been mentioned by Dr. Aravinda Jagdeesha, they are macrovascular and microvascular, but I will focus on this complication of nerves, that is the neuropathy, and that to peripheral and that to painful neuropathy. So diabetic neuropathy, leading cause of non-traumatic lower extremity amputations that we all know about. The most common of all the late complications of diabetes develops within 10 years after onset of diabetes in 40 to 50% of the patients with diabetes. But in some type 2 diabetic patients, they already have neuropathy at the time of diagnosis. So that is what we say, that type 2 diabetic patients, we should go for these investigations right at the time of first visit, and in type 1 diabetic patients at 5 years of duration. And they can lead to foot ulcerations, Charcot neuroarthropathy, and amputations without proper foot care. 45% of the lower extremity amputations occur in patients with diabetes. How can we define it? Presence of symptoms and or signs of peripheral nerve dysfunction in people with diabetes after other causes have been excluded. So this is the diagnosis of exclusion in a diabetic patient, but supported by the symptoms and signs. The pain in a diabetic patient, that may be nociceptive pain, it may be neuropathic pain, or it may be a mixed type of pain, which may be caused by a combination of both primary injury and secondary effects. The nociceptive pain is caused by activity in the neural pathways in response to potentially tissue damaging stimuli, like the postoperative pain, the mechanical low back pain, arthritis, sickle cell crisis, sports or exercise injuries, and neuropathic pain, which is the post-herpetic neuralgia, neuropathic low back pain, distal polyneuropathy, central post-stroke pain, trigeminal neuralgia, and other such pains. Now, what are the features of diabetic neuropathy? It is diagnosed in the presence of 2 abnormal symptoms or signs, frequently asymptomatic and mostly untreatable. Requires careful examination, assessment to detect. It affects the quality of life, which is very important. Patients with diabetic neuropathy are 15 times more likely to have lower limb amputation, and foot problems are very common. The various risk factors: glycemic control, dyslipidemia, hypertension, body mass index, smoking, excessive alcohol. So both smoking and alcohol are other culprits which increase this, and they are the modifiable factors. Then the prevention or delaying the onset of diabetes. But the non-modifiable factors are age of onset of diabetes. Early the age of onset of diabetes, more are the neuropathy. Duration of diabetes, long-standing diabetes can lead to further neuropathy, genetic factors, and presence of other complications of diabetes mellitus. I'll hurriedly go through the etiology and pathophysiology. There is alteration in the nerve blood flow. There is Schwann cell dysfunction leading to primary demyelination, secondary segmental demyelination due to impairment of the axonal control of myelination. There may be neuronal degeneration and progressive impairment of regeneration. There may be neuronal damage caused by the hyperglycemia and the oxidative stress. We see here that the microvascular damage leads to the diabetic peripheral neuropathy, which you can see on one side the normal nerve, on the other side the damaged nerve. And very important is diabetes and endothelial dysfunction. Through the hyperglycemia, through the insulin resistance and free fatty acids, there is oxidative stress, AGEs, leading to endothelial dysfunction, and that again leads to vasoconstriction, inflammation, atherosclerosis, and this leads to the complication of diabetes. Now, what is the mechanism of hyperglycemia-induced damage? This, as I told you, through the increased polyols orbital pathway, the hexosamin pathway, the protein kinase C pathways, and the AGE pathways. Progression, patients divided into two distinct entities: those who progress gradually, that is the sensory and autonomic, and those who have a relatively explosive onset and experience remission almost completely. They are the mononeuropathy, radiculopathy, acute pain-filled neuropathies. And the progression of diabetic sensory polyneuropathy is related to glycemic control in both type 1 and type 2 diabetic patients. And we can see here that clinical features of the diabetic neuropathy: large fiber neuropathy, small fiber neuropathy, proximal motor neuropathy, acute mononeuropathies, and pressure palsies. And you can see here that the femoral neuropathy, there is sensory loss, there is pain, there is tendon reflexes absent, and there may be motor deficit. In sensory loss, there may be other acute mononeuropathies that will be truncal or involving the third and the sixth cranial nerve, where there is sensory loss, pain is there, tendon reflexes are normal, motor deficit may be there, pressure palsies like median nerve palsy or ulnar nerve or lateral popliteal nerve palsies. So the signs and symptoms of peripheral sensorimotor polyneuropathy are distal, bilateral, symmetrical, Stoke and glove distribution. Symptoms range from numbness, that is the deadness, to severe pain, burning, alteration of temperature sensation, paresthesia, shooting or stabbing pains are common, and it may worsen at night, minor motor involvement causing weakness. And the pain and the symptoms of painful diabetic neuropathy, only the patient who experiences it can know how much debilitating it is. There may be decreased or absent reflexes, loss or diminished vibratory sensation, muscle atrophy, foot complications like ulceration, blisters, or deformities like the Charcot's joint. Now, the important is neuropathy screening, because when we try to manage any problem, we have to look for the diagnosis, the screening, and then we go on to the treatment part. So evaluate the feet at every interim physical examination, annual screening, and screen for loss of or decreased ankle reflexes, loss of or decreased perception of the vibration in great toe, loss of or decreased sensitivity to 10-gram monofilament in great toe. And I'll tell you further that it hardly takes 2 minutes in examining the foot. So the 2-minute foot examination is examine feet for ulcers, callus, blisters, maceration, skin breaks, infection, or change in the skin color of the dorsum or of the ventral aspect of our foot. Examine the toenails, identify nature of any foot deformity, examine the shoes, observe patient's ability to perform foot care and examination. By observing them, replace socks and shoes, and establish the need for patient education, which is very, very important. Now, how to evaluate the nerve functions? There are tests of sensory functions like vibration perception threshold, which may be measured by biothiometer, 128 HZ tuning fork, Riedel Cipher graduated tuning fork, or the vibrometer. The biothiometer used commonly to measure the vibration perception threshold. It uses an electromagnet to activate a spring loaded stimulator according to an arbitrary scale from 0 to 50 volts. The intra-subject coefficient of variation is in the range of 20 to 30%, and threshold usually rise with age, and detailed age-related mnemograms may be needed in proper evaluation, and it is a very, very simple test. The other is light touch sensation may be assessed by 1 Frey horsehair or nylon monofilaments, and then the Siemens-Weinstein monofilament can also be used for the test. And this is what we do regularly in all our diabetic patients, the biothiometry study and the monofilament 10-gram study. With that, we look for the touch and for the vibration senses at different places on the sole of the patient on both sides. Then thermal threshold, warm and cold sensation should be tested separately. This warm is mediated by the smallest unmyelinated C fiber and the later by small myelinated A fiber. So that is how we differentiate between the two, whether they are the small fiber neuropathy or it is a large fiber neuropathy, or it is a unmyelinated C fiber or by the myelinated A fibers. The heating and the cooling detector uses the Peltier principle, that is the metal elements are heated or cooled according to the direction of flow of the electric current. And the Marstock stimulator is often used to detect the thermal thresholds, and it's very easy. Now, how to manage, which is very, very important of the diabetic neuropathy. The scope of neuropathy management is prevention of neuropathy through tight glycemic control, and the goal is to achieve the normal levels. If the patient develops neuropathy, that cannot go back to the normal. Some element of neuropathy will always remain, patient will always remain symptomatic to certain levels. And to control the neuropathy pain, we have many drugs available, which I will discuss further, and then we have to prevent of the foot complications. And these guidelines have been taken earlier. These guidelines were from the American Academy of Neurology, evidence-based guidelines, treatment of painful diabetic neuropathy. They were given in the year 2011, and again they have revised in 2021. Patient assessment and counseling, assessment of neuropathic pain and its impact on patients' function and quality of life, which I have told you. Patients be conscious that the aim of pharmacological treatment is to reduce pain. Pain may not be totally eliminated, and patients with painful diabetic neuropathy may be assessed for mood and sleep disorders. Even they have obstructive sleep apnea and managed accordingly. There is no relationship between pain reduction and age or between pain reduction and gender. Typical duration after which efficacy is seen is 12 weeks, 4 to 16 weeks is the usual time. So when we start any treatment, we should at least wait for minimum 4 weeks to 16 weeks. And even after 12 weeks or 16 weeks, there is no significant improvement, then that is called as the treatment failure. And treatment considered intolerable if side effects outweigh the benefits, then alternative agent may be tried. The various oral drugs available are the gabapentinoids, serotonin, non-epinephrine uptake inhibitors, tricyclic antidepressants, sodium channel blockers, and others. And the use of opioids strongly has contrasting views, with some authorities discouraging it because they are habit forming, and once the opioids are started for this kind of pain, it becomes very difficult to stop these medications. The gabapentinoids, calcium channel alpha-2 delta ligands, they are the pregabalin. The evidence is level A, dose is 300 to 600 milligram per day. The dose which we use here is 75 milligram. Start with once at night, then increase it to 75 milligram twice a day. But I think many of us are not using the dose which is prescribed here, 300 to 600 milligram. Then the gabapentin, which is evidence is level B, dose is again very high, 900 to 3600 milligram per day. More appropriate in those with coexisting seizure disorders. Side effects are peripheral edema, should be avoided in CCF, renal and liver disorders. Serotonin, non-epinephrine uptake inhibitors, the duloxetine, again the evidence is level B, dose 60 to 120 milligram per day. Venlafaxine is again an antidepressant drug, which is also used in diabetic painful neuropathy in the dose of 75 to 225 milligram per day. Desvenlafaxine dose is 37.5 to 225 milligram per day. And the beneficial effect on mood and sleep, they have more appropriate in those with coexistent anxiety or depression, venlafaxine, desvenlafaxine, and then comes the duloxetine. Side effects are nausea, fatigue, and dizziness. The tricyclic antidepressants, norepinephrine uptake inhibition like amitriptyline, the level B evidence inhibits serotonin uptake as well. Dose is 25 to 100 milligram per day, nortriptyline dose up to 100 milligram per day. But we see that there is a combination of pregabalin and nortriptyline or amitriptyline, nortriptyline usually we use, but the doses prescribed here or shown here in our setting, we consider it too high. So we use with a small dose. They also have a beneficial effect on mood and sleep, more appropriate in those with coexistent anxiety or depression. Side effects are worsening of constipation, urinary retention, and orthostatic hypotension. So they should be used very cautiously in elderly people. Then comes the sodium channel blockers, the valproic acid. Dose is 500 to 1,200 milligram per day, more appropriate in coexistent seizure disorder, but they have a lot of side effects, nausea, fatigue, and dizziness. Valproic acid is teratogenic, hepatotoxic, may cause pancytopenia, hyponatremia, pancreatitis, and valproic acid should be avoided in women of childbearing age. So it is a tricky medicine and it should not be used very commonly. Now comes the opioids. Dextromethorphan dose is 400 milligram per day. Morphine dose titrated to 120 milligram per day. Oxycodone mean dose is 37 milligram, maximum is 120 milligram. And then tramadol also inhibits norepinephrine and serotonin dose 220 milligram per day. And people have been using tramadol for a very good dose, and especially those people in the neurologist and the orthopedic surgeons, we all have seen that they use this drug tramadol in and out. The side effects are tolerance, which is very important. Addiction potential, again, a significant side effect, constipation and the rebound headache. Then the other drugs available, they are Nebulon, synthetic cannabinoid, Filorixant, that is orexin antagonist, vitamin E, citalopram, mexilatin. Both these drugs have shown inconsistent data and they are not approved by FDA. The topical agents, they are capsaicin, level B, nitrosense patch, level B, glyceryl trinitrate spray, then the topical clonidine and buprenorphine transdermal spray, they have also been used. The other non-pharmacological interventions, they are the percutaneous electric nerve stimulation, 3 to 4 weeks, exercise, mindfulness, and cognitive behavioral therapy, which is very, very important in these patients. We have to spend time with the patient, explain to the patient how much improvement is expected, how we will assess the drug action, and how we will change the treatment. Otherwise, if you do not explain to the patient, patient will go for window shopping, and the next person, next doctor looking after the patient will start the higher dose and it will keep on going. So this is what is there. So the summary of recommendation is level A is pregabalin, level B is gabapentin, sodium valproate, venlafaxine, duloxetine, amitriptyline, dextromethorphan, morphine sulfate, apomorphine, tramadol, then the oxycodone, capsaicin, isosorbide nitrate spray, and electrical stimulation. And the drugs which are not recommended are oxcarbamazepine, lamotrigine, lacosamide, clonidine, pentoxifylline, mexilatin, magnetic field treatment, and the low intensity laser therapy. So the guidelines at a glance, pregabalin is established as effective and should be offered for relief of peripheral diabetic neuropathy. Venlafaxine, duloxetine, amitriptyline, gabapentin, valproate, opioids, and capsaicin are probably effective and should be considered for treatment of peripheral diabetic neuropathy, painful. Other treatments have less robust evidence or the evidence is negative. Effective treatments for painful diabetic neuropathy are available but may have side effects that limit their usefulness, and few studies have sufficient information on treatment effects on function and the quality of life. The neuropathic pain non-pharmacological treatment, we can see that the meditation, imagery, biofeedback, relaxation therapy, physical rehabilitation, acupuncture, transcutaneous electric nerve stimulation, they all have been tried and have some relief. So to summarize, neuropathy is a multifactorial problem. The most common complication and greatest source of morbidity and mortality in diabetic patients. Once a patient develops neuropathy, there are few treatments proven to be effective, and the unmet need of diabetic peripheral neuropathy has to be addressed and needs to be managed with either the new convincing formulations of the existing molecule or with the newer agents to have a control. Foot care is essential in preventing neuropathic complications. And my appeal to all my physician friends, please spend 2 minutes of yours in looking after the feet of the patient, so that if diabetic neuropathy develops, we can pick up that at a very early stage. And very important is tight glycemic control to prevent development of painful diabetic neuropathy. But please look for hypoglycemia also, because that is also very important. Thank you very much. I'm sorry for the technical glitch we had at the start.
Thanks, Dr. Professor J.K. Sharma, for your excellent talk. You have covered all the needed points in your talk. I think only 1 or 2 questions may be entertained now.
One question I will like to ask to Professor J.K. Sharma after his wonderful deliberation.
Yes, sir.
Since there are so many molecules available, it is quite apparent that ideal treatment is not available. From your experience and knowledge, sir, how many cases are resistant to all these treatment, and whether any pancreatic transplantation has got any role in such cases?
So regarding the painful diabetic neuropathy, the first and foremost is the control of hyperglycemia, because that is very, very important. Second is that if the patient is smoker, we have to make sure that patient stops smoking and alcohol as well. Then if there is a deficiency of vitamin B12, especially, and in vegetarian people on metformin therapy, because metformin is our first line of treatment and we keep using metformin. So if there is a B12 deficiency, that has to be corrected. If vitamin D, there is no direct role has been shown by vitamin D, but that also gives a good result with vitamin B12 in improving the diabetic neuropathy that we have seen. And tight glycemic control, patient should not go into hypoglycemia. And in that case, a good number of patients with minimum of the medications, like we start with pregabalin 75 milligram, even we start with 50 milligram of pregabalin at bedtime, then we increase it to 75, and even we increase it to 75 milligram twice a day. And in certain patients, we even add duloxetine 20 or 30 milligram. And with that, there is a good result. But if the sugars are not under control, none of the treatment is going to help us.
Thank you.
Thanks, Dr. Jha.
I have to add something. Can I add?
Yes, Dr. Meena.
So, Dr. Sharma, sometimes you see people not respond. This is to Dr. Jha's question, that which one is more effective. So I think sometimes people who don't respond to pregabalin may respond to duloxetine or a combination. Sometimes the dose limitation is there, because the moment you increase the dose, there may be a lot of drowsiness. So some patients cannot tolerate higher doses of pregabalin, and you have to gradually build it up. And the other thing is, when you control blood sugar, and there's a sudden drop in blood sugar, then neuropathy can be precipitated. Sometimes when we start insulin for people who have severe hyperglycemia, they may complain of neuropathic symptoms. So again, that is important also, that sometimes rapid control of hyperglycemia can lead to neuropathy. So Dr. Jha, your answer to your question is that sometimes you have to keep changing, and higher doses of gabapentin are not tolerated. And yes, there is a group of patients which does not respond to any treatment. It's quite difficult once the patient develops painful neuropathy, and they tend to become addicted to opioids.
And we have to look for insulin, because of insulin, the insulin neuritis also, that we have to consider. And in certain patients, if we add 10 milligram of nortriptyline along with 75 milligram of pregabalin, that combination also have a very good result.
I have a comment, sir.
Yes, sir.
Very nice presentation. Very nice presentation. But whatever we use, maybe pregabalin or gabapentin, that is for the symptomatic relief of the pain. Are we controlling the pathophysiology?
No.
We are not controlling the pathophysiology of diabetic neuropathy, which has happened, and the knobs are affected. Especially when the patient is having autonomic neuropathy, it's still very painful, in the sense the GI tract, the heart, the autonomic involvement of the organs gives the patient a
bladder,
gives very poor quality of life.
Very poor.
So how can we help? What are the interventions we have now to improve the pathophysiology of diabetic neuropathy, especially autonomic neuropathy?
Dr. Jayant, first of all, thank you very much for your comment, but the topic given was painful diabetic neuropathy, number one. So I have not covered autonomic neuropathy.
Should we sit down curbing the pain, or we should go a little further?
No. We have to make the patient understand that this is only a symptomatic treatment, and these drugs are going to help you if your sugars are under control, if you don't smoke, if you don't take alcohol. And then regarding the autonomic neuropathy, long-standing diabetes patients do develop autonomic neuropathies, and there is no specific treatment, as we all know, and we cannot change the pathophysiology. If you can suggest any drug which can change the pathophysiology of the neuropathy of diabetes, please let us know.
Yeah, there's some role of ALA, and people keep giving methylcobalamin, ALA.
Alpha-lipoic acid.
That is methylcobalamin is only if there is B12 deficiency.
So I think
aldose reductase inhibitors.
Yeah, they keep giving.
They are all, placebos. They don't have any definitive data to prove.
Yeah.
Yes.
The only thing I just say two things. The first thing is the best way is to have tight glycemic control right from beginning so that you can prevent painful neuropathy.
Yes.
Once painful neuropathy develops, it is a recalcitrant condition and very, very difficult to control.
Yes.
But having said that, in my personal experience of last more than 40 years, I have got the best results with a combination of pregabalin, prolaxetin, and capsaicin local application. And these three has worked wonderfully in majority of the patients. Yet around 20% of the patients still keep on complaining. And that's a big problem.
The warmth of the extremities with cold toes, and then cramps. Cramps are also one of the features of painful diabetic neuropathy, and it is because of the unmyelinated small fibers getting involved.
Right. We don't have any drugs to change the pathophysiology, Jan, but unfortunately, that's the biggest problem. But now we have so many creams, local application creams like Diafood cream is available, and that gives wonders. Patients at least have a good quality of life, and they're able to sleep in the night.
Yes. The counter irritants we use gives some relief, but the unfortunate, I think there are few monoclonal antibodies are in the process, and maybe in future we'll have some intervention.
Future, yes,
right.
Yes.
Over to Dr. Jha for the next speaker, please.
Yes, we should move to the next topic. I request Dr. S. Jha to chair the session.
After a very brainstorming session on painful diabetic neuropathy, we are coming to the last topic of the day. Last but not the least, extensive research is going on every day. And out of it, American Diabetic Association every year is giving some upgradation. So all of us, all physicians across the globe are very much interested in knowing what is new this time. And our topic for this evening, last topic, is ADA, what's new, ADA 2022. And to deliberate on this topic, we have got an eminent consultation physician and cardiodiabetologist from Kolkata, Dr. Bijay Patni. He is HOD, Diabetes Wellness Clinic, Kolkata, founder, Diabetes Research and Welfare Association, scientific chairperson, 7th Annual Conference, DRWA 2019 and Diabetes Update 21, faculty at Omron Academy, scientific chairperson and course director, Diabetes Activist Certificate Program, January 2021, regular speaker and faculty at various local and national conferences like BPCon, DIPSI, RSSDI, ACP, ISCM, NCCD, CardioDabCon, NUCD, etc. Awarded Investigator of the Year Award in BPCons 2017, awarded GAPIO honors for month of September 21, participant in various studies and clinical trials, contributed articles and chapters including independent studies in journals, books, presented oral paper presentations in various national and international conferences, associated with various NGOs of West Bengal, and conducts various medical camps at regular intervals, life member of various professional bodies like RSSDI, GIPSI, DFSI, IDEA, ISH, DRWA, GAPIO, ITS, ISCM, CCDSI, ACP. The stage is yours, Dr. Bijay Patni.
Thank you, CCDSI, Bihar and Jharkhand. Thank you, Dr. Jha, for an extensive, I think, introduction, which probably was not needed. We wasted 2 minutes. And thank you, all the three speakers. I mean, we had extensive discussion on all three different topics. And I think I gained a lot from all the three topics. So now, so thank you, Dr. Virmani, for giving me this talk. This is ADA Standard of Care 2022. What's new? What I'm going to do is basically, before going into the new part, we will go as discussed with Dr. Virmani for a hypothetical case. How can we evolve the management tool which has been advocated in the standard of care for that particular patients?
Dr. Patni, can you please make it full screen?
Yeah.
No, yes. Thank you.
Okay. Thank you.
Thank you.
Okay. So we are all aware of the global prevalence, and as for 2019 statistics, 77 million diabetics in India. And over the years, we have seen a whole lot of molecules being added in the armamentarium for managing diabetes. And the recent one, obviously, is oral semaglutide, which was launched sometime on, I think, 15th of Jan. So these are going to be there, but in spite of the fact that we have so many molecules and so many newer modalities being added to management, still we have incidence of diabetes increasing, and we might land up with 134 million by the year 2045 as per IDF. So we all have to go to the old saying that prevention is the best cure. Now let's see, we all know about type 2 diabetes. We all thought it was just sugars. Probably a lot of stuff has been talked today as well. The pathophysiology, which is more important, liver fat or the blood in the glucose in the blood. But what is more important is what happens at the pre-diabetic stage and or when you diagnose early as far as type 2 diabetes is concerned. Now, they themselves are a high-risk group, high CV risk, and you add on to that increased insulin resistance or beta cell dysfunction, you will be landing up with advanced type 2 diabetes where you will be having end organ dysfunctions. And whenever your diagnosis a pre-diabetic or even a type 2 diabetes, what happens as far as the Indian scenario is concerned, or the subcontinent scenario is concerned, that we are late in diagnosis diabetes. When we're diagnosing diabetes, at the same time, we're having lots of comorbid conditions already associated with it. And maybe some of the micro and macrovascular has already started. So what we know in these kind of population, that 30% of them have diagnosed CV disease. 20% where the eGFR is less than 60 ml. 20% might be having albuminuria. 50% may have a comorbid hypertension. And obviously, these population have twofold premature CV mortality. And then you have the gamut of microvascular complications like retinopathy, neuropathy, and amputations. And we are all aware of the fact that diabetes is the largest category on dialysis register. So basically what we want to say is that the diagnosis need to be made early, a proper screening procedure need to be employed so that we diagnose them early, even at the pre-diabetic stage, because all what's Professor Roy Taylor has said that reversal can happen, and that usually happens at the pre-diabetic stage if you can prevent the pre-diabetes from progressing to diabetes, or very early in the type 2 diabetes. So these are very important points which need to be taken into consideration. Now, over the years, there is evolving guidelines, and Dr. Jha said every year they bring out with the standard of care. So what are the changes over the years from 88 2008 to 88 2021 and then to 22? Now, obviously 2008, if you see, it was mainly treat to target, emphasis being on glucose, weight and hypos. Sorry. And there the CV risk was treated separately. It was thought as a separate entity and was treated. And then we followed that stepwise pattern of modulating or modification of the drugs. We started with the lifestyle, metformin, and then the targets were not there. Then you have the oral combination. That time it was basically the sulfonylurea and glitazones to be added on. And then you add on insulin if the targets are still not achieved. Then in 2012, with the introduction of some newer molecules like DPP-4 inhibitors, there was increased flexibility and use of combination as far as the use of combination is concerned. And you could see that after metformin, there was a whole different drugs were there for as a two drug combinations. So this was the change where DPP-4 inhibitors were added. In 2015, there were more flexibility, there were more emphasis on individualization, and here SGLT2 inhibitors came into the picture. So obviously, as an add-on drug to metformin, you have SGLT2 along with the other molecules which were prevalent there. So this was the patient-centric approach which I revocated, and emphasis started on individualization of the therapy. Now 2018 and 19, here the whole change happened actually. From glucocentric, we went into the holistic management, a little bit on the CRM axis, I would say rather. Because the CVOT data started coming in on the newer molecules, because that was mandated by FDA in 2008. And then the CVOT data came in, and then the whole focus shifted on the phenotype of the individual, means the associated comorbid conditions or the presence of them or other major factors were taken into consideration. So here, whether the presence of atherosclerotic CVD or risk or CKD or HF was taken as a separate entity, and here the molecules were different. So, and then there were other features like a compelling need to minimize hypoglycemia, promote weight loss, and cost or access was another issues which were taken into consideration in 2018-19 guidelines. If you go into 2019, it went a little further. Now more data were there. The EMPA and the DAPA and all the SGL2 trials had come out with different data as far as heart failure and CKD were concerned. So here they separated the heart failure and CKD in their version. And you can well appreciate from this particular photo that yes, here, which was initially incorporated, these two were incorporated, they were now separated. And now emphasis was made that depending upon what the features are, you can choose your medication accordingly. So these have been the changes across from 2008 to 2019. So we have moved from a glucocentric approach to a holistic approach. So what's there in 2022? So as discussed with Dr. Virmani, we are starting with a hypothetical case to incorporate what is there in standard of care 2022. But this is the most important slide, I would say, because this gives you an idea how you are going to approach your patient. So the goal of the care has to be to prevent the complications and to optimize the quality of life. So first and foremost, you have to assess the key patient's characteristic. What's his lifestyle? What is economic status? What is the comorbid condition? And all this stuff need to be taken into consideration. And thereafter, consider these specific factors which can impact the treatment, like individualized HbA1c target, the complexity of the regimen, the access, cost, and availability of medication. All these things has to be taken into consideration while which can impact the choice of treatment. And the third and the most important part, I would say, presently every physician needs to concentrate on that we have to plan a management sitting across table and have a shared kind of decision making while planning out a management plan. And that is empowering the patient, and along with that access to the DSMEs as well. Once that decision is taken that this is the plan which we are going to take, then we have to agree on the management plan depending on which will be very specific, that should be measurable, that should be achievable, realistic, and time limited. Once you have agreed on a management plans, now you have to implement the plan, and you need to focus that the proper follow-ups are there, so that you can really see the progress, how it is going, the patient is making as with this management tool which we have advocated for the patient. And thereafter, ongoing monitoring and support is needed. You have to really, the major impact has to be on the psychological aspect. The emotional quotient has to be there. The empathy should be there throughout the management. So you have to make sure that the patient is following your directions or the shared decision which have been taken, and the monitoring is showing a sufficient kind of control. And then obviously you have to review and agree on the management plan further if any changes are needed, or so that you don't develop the clinical inertia. That inertia can come from our part mostly. So that is, again, we have to address the issue. So the whole goal is to prevent complication and optimize the quality of life. Now, taking those into consideration, now let's look into this case. He happens to be a 42-year-old male patient. He has been recently diagnosed with type 2 diabetes. His blood pressure is well under control. His BMI is just about normal. The current laboratory results show the HbA1c of 7.2%, the fasting of 120, and PP of 170. The LDL is 90 and eGFR is 110. Now, considering this standard of care, what has been shown, what should be the ideal way of managing this patient? This patient is only having a glucose problem. He is having an issue with the glucose, and maybe you might say that the LDL is above targets. So look back into this particular slide, and you will appreciate the fact that this patient, if you look at the first line therapy, that which depends on the comorbidity, patient center, etc., and generally includes metformin and lifestyle, that is should be considered in this particular patient. So that should be the treatment of choice for this particular patient. So the reference case happens to be a young patient, 42-year-old, newly diagnosed, no comorbid. So the choice of drug remains metformin, along with reiteration of lifestyle education at every visit. Now, obviously, the diet, physical activity, and behavioral therapy need to be focused on and need to be properly educated, be part and parcel of the management tool. And the whole idea should be a loss of 5% weight, and that will be able to achieve the targeted, not only the glycemia, overall targets are good as well. If the weight loss is much more, then obviously there will be improvement in control of diabetes and cardiovascular risk as well. So such intervention should include, this is very important, this is a focused area in the ADA standard of care, high frequency of counseling, more than 16 sessions in 6 months, and focus on dietary changes, along with physical activity and behavioral strategies, so that you have an energy deficit of about 500 kilocalories. So that is the plan for this gentleman. So obviously, while choosing the drug, the focus should be on the weight, and so that you add on any medication which doesn't have an impact on the weight, and the behavioral counseling should be paramount. So this same patient, now in 8 years' time, he is 50-year-old now. He has been diabetic for 8 years. He has history of MI. He has a blood pressure of 140/90, and the BMI has gone up to 26. And there has been some kind of financial upliftment in the individual as well. The HbA1c is 7.8%, fasting is 140, the PP is 190, LDL is 120, eGFR. Now you all will agree with the fact that now he has lots and lots of issues. So after 8 years of diabetes, now he has a whole lot of issues. Again, let's go into the same slide, the algorithm. And now you will agree with the fact this gentleman had a history of MI. That means we are going to tell you further when is the MI happened and all this stuff, and why he came so late. So basically, that was already a known atherosclerotic CVD. A special emphasis have been laid out in this algorithm for the person who are having known atherosclerotic CVD. It has to be the GLP-1 receptor agonist with proven CV benefit or a SGL2 with proven CV benefit, because these are the ones which are advocated for established atherosclerotic CVD. Along with there was the issue with the weight. He has gained weight. The BMI have risen from 24 to 26. The blood pressure has gone up. And then you can see the LDL cholesterol has increased, and eGFR has also gone marginally down. So now what should be the treatment of choice? So this is the indicated treatment for this gentleman now. So this is important. So we all agree that it is a multifactorial approach in a patient of diabetes. So the foundation obviously has to be the lifestyle modification with diabetic education. And to reduce the diabetic complication, you need to have an effective glycemic management. You have to manage the blood pressure. You have to manage the lipid management. And those, you have to use the agents with cardiovascular and kidney benefits. So in this gentleman now, probably we have to address all the 4 issues. So that is what the standard of care has given this slide. And it is really a good one, I would say, because it gives an idea that the glucose need, the diabetes need to have a holistic approach for management. So what happened to this reference case? He lost to follow-up. But somewhere his medicine has been escalated to fixed dose combination sulfonylurea and metformin. And we all know he was diabetic for 8 years. He had a MI 1 year back. He has a history of hypertension 5 years back on medication. And now he's overweight also because his BMI is 26. So recommended as per the algorithm is that independent of the baseline or individual A1C target or metformin use, you have to use an agent which is recommended for a established atherosclerotic CVD or atherosclerotic CVD. The choice could be either GLP-1 receptor analog with proven CVD benefit or a SGL2 inhibitor with a proven CVD benefit. And if the HbA1c not target, you can add on to the other molecule, whichever you are not using as a first-line therapy. So it's a very clear-cut kind of advice or the guidance given by these guidelines that which are the molecule now needed for this gentleman. The same gentleman who has developed MI 1 year back, that is at the age of 49, and has developed hypertension for last 5 years. So for patients with diabetes and hypertension, blood pressure targets should be individualized. Those who have a higher cardiovascular risk, the target has to be less than 130/80. And those who have a lower risk of cardiovascular disease, the target is less than 140/90. Lifestyle modification need to be taken into consideration every time. The focus has to be on weight loss. You have to reduce saturated fat and trans fat, increase the dietary N3 fatty acids, increase the viscose fiber, increase the physical activity, and you have to initiate the statin therapy, particularly in this reference case, because along with lifestyle, you have to use that because of the increased additional atherosclerotic CVD risk. Lipid levels are not under control as well. Now, the same gentleman through his journey has, after 10 years, developing stage B heart failure. Blood pressure is still 140/90. The BMI is 23. HbA1c has gone up to 8.8. Fasting 160 pp, 210. LDL 110. eGFR 90. So we all understand it is a progressive disease. Somewhere or other, if we are lacking in proper count of counseling, and the patient is not there for follow-ups, as we planned out a comprehensive medical examination, as the first slide which I showed you, if that is not followed up rigidly, then probably this is what is the fate would be. So now the patient has come up with a heart failure. Let's go to the algorithm once again, and you will appreciate there is a special block for patients with heart failure. It's clearly written the SGL2 with proven benefit in the population. This is the one. So this should be the treatment of choice. Now, if he's not been initiated on SGL2, now initiation of SGL2 is important. So this patient, again, has now been coming with a stage B heart failure. So as recommended, we will agree to the fact that SGLT2 inhibitor with a proven heart failure benefit need to be introduced, and patient with type 2 diabetes and established heart failure with reduced ejection fraction, SGLT with proven benefit will reduce the worsening of heart failure and cardiovascular death. Already lots and lots of study have already pointed to it. Now with even heart failure with preserved ejection fraction, the SGLT2 has shown some benefits. So the same gentleman, after 12 years, now been diagnosed with CKD. And if you look at the eGFR, it is 30 and a UACR of 130 is being reported. Now there could be a discrepancy between eGFR and UACR. This is basically taken care by this standard of care guideline, which I'm going to talk about later. 1 in 3 adults with diabetes may develop chronic kidney disease. Now the whole focus has changed. It's no more the glucose which is going to have any influence. It's basically the kidneys and the prevailing heart condition which need to be taken care of. Let's go back to the algorithm. And it is the CKD, a very specific kind of indication being given here. And obviously this patient now will be needing SGLT2 if not already on. So there are different parameters which are the drug SGLT2 or a GLP can also be initiated depending on the albumin label. So this patient now is 10-year-old, diagnosed with 12 years old, with diagnosed with chronic kidney disease. So here we divide them according to the presence and absence of albuminuria. This patient had albuminuria, so obviously this patient will be having SGLT2 inhibitor with evidence of reducing CKD progression or GLP-1 with proven CVD benefit. Now those who have without albuminuria is still introduced as a first the first choice as GLP-1 receptor agonist analog. So if in each case the A1C remains above the target, intensification depends on comorbid, patient-centric and management needs. So the key consideration also includes to minimize hypoglycemia. As we showed, these are other factors which need to be taken consideration. Older adults with diabetes have a greater risk of hypoglycemia. Episodes of hypoglycemia should be ascertained and addressed at routine visits. The choice of drug, obviously, in this patient will be DPP4, GLP, SGLT2, and TZT. Minimizing the weight gain and promote weight loss is another optimum way of managing these patients. So you have to consider those medications which doesn't have much impact on weight, or they at least do not cause weight gain. So these are the choice of drugs. Every one of us are aware of it. GLP-1 receptor analog SGLT2, if not tolerated, and DPP4 can be considered because it is weight neutral. Consider the cost as excess. That in that case, obviously, the generic form of insulin and sulfonylurea and TZDs can be utilized. And in older patient, one need to be very aware of that you have to screen for geriatric syndrome, neurocognitive functions, be careful about hypoglycemia, and the treatment goal has to be individualized. You have to manage other comorbid condition equally, and dehydration should be avoided and treated. This is a busy slide which is there in the standard of care, where probably everything and anything of drug as well as the patient's centric approach has been clearly outlined. You will see, and this is a very good, it's a chart. One should always, actually go through it, because it gives lots and lots of information about the individual drug and the patient characteristic which will be applicable to that drug. And you can utilize them for the management as a management tool. So the take-home message, what I would say, is that type 2 diabetes management should be based on evidence-based guidelines, collaborating with the patient individual preferences and prognosis and comorbid conditions. Emphasize on the following: patient-centered care, integrated long-term treatment approach to diabetes and comorbidities, ongoing collaborative communication and goal setting between all team members. Also important to assess the diabetic healthcare maintenance with attention to the financial consideration. So this is what I try to wait as a base before I go into what's new. I think we can, just looking into the algorithm, we can plan out our therapy for any individual patient because that is what is advocated by the ADA. Now let's look at the ADA, what's new. I have divided that into 4 major areas. One is screening, another one is individualized care, number 3 is comorbidity, and number 4 is glycemic assessment and technology. These are the 4 major areas. There are a few other areas as well, but these are the 4 major areas where there is something new has happened as far as this standard of care is concerned. Now let's look at the screening part. Every individual who is overweight or obese, who is above the age of 18 or having more risk factor, need to be screened for diabetes and pre-diabetes. The second most important part is screening asymptomatic individuals at the age of 35, which may not be relevant from Indian point of view. I think we need to screen much earlier, maybe at the age of 30, but this is what they have come down from 45 to 35. Normal test, if you get on screening, they need to be screened every 3 years unless they develop some symptoms or are at a risk. Important fact, exclude point of care HbA1c as a test for diagnosis of diabetes. This is very, very important. They have made mention of it. The second one is the genetic testing. Whenever you're suspecting, particularly when suspecting for maturity onset diabetes or in young or in child, basically you need to go for genetic testing. And regardless of the current age, if individuals are diagnosed under the 6 months of age, should have its genetic testing. So that's are the 2 important considerations where you have to go for a genetic testing. Now, in pregnant ladies or who are planning to get pregnant, that is a preconception time. In who are planning pregnancy, screen those with risk factors and consider screening all women for undiagnosed diabetes. Universal screening for those who are planning for pregnancy should ideally be undertaken, or at least those who are at risk. Or if you have missed out there, then you should at least screen at before 15 weeks those women with risk factor and consider screening all women for undiagnosed diabetes at the first prenatal visit, using standard diagnostic criteria, if not screened pre-conception. So this is an important element which have been added in this standard of care. Thirdly, for type 1 diabetes, what they say is if you have a patient who probably are prone to develop type 1 diabetes or at risk of diabetic, or they are first degree relative, then if there is a presentation or DKA of the age is less than 35 or the BMI is less than 25, you need to screen for type 1 diabetes as well. The second major change has happened in the individualized care, and this goes very well that one size doesn't fit all. Obviously, you have to individualize the therapy. We have to give a personalized medicine for every patient. Now, these are the 5 considerations which I have shown already in the algorithm: the presence of comorbidity, the chances of hypoglycemia, the impact on weight, the cost and the access of medication, and efficacy of different treatment regime. These 5 things need to be taken into consideration in type 2 diabetes. And this is the algorithm which I've already discussed with you, which have clearly shown the different factors which have been considered while picking up a particular molecule for managing your patients. Along with that, this is a very important and good chart they have given, that is simplification of insulin therapy. One should always go through it. They have streamlined where the basal insulin, whether patients on basal or on prandial or patients are on premix, you can simplify them and accordingly achieve the targeted. One should at least go through this slide so you get an idea about when and how to modify the therapy. Then the stress has been made on type 1 diabetes, which is insulin dependent. Obviously, insulin therapy had to be advocated for them. And the 3 major criteria which have to be taken into consideration: the flexibility, the lower risk of hypoglycemia, and the higher cost. These 3 will define which insulin regimen will fit for your patient. So obviously you will use a regimen which mimic physiologically as closely as possible, but these 3 are the limiting factor which will define your insulin regimen which you are going to plan out for your type 1 diabetes. Similarly, if you are planning for a multiple daily injection of prandial and basal insulin or continuous subcutaneous insulin infusion, again, these 3 criteria will define whether you will go for hybrid closed loop technology, whether you're going to insulin pump with threshold predictive low glucose suspend, and or insulin pump therapy without automation, because the high cost is going to change the risk of hypoglycemia is going to change, the flexibility issue will come in. So you have to understand which is the best one for your type 1 diabetic patient as far as the continuous subcutaneous for this kind of insulin pump is being used. So greater benefits have been seen with algorithm-driven automated basal insulin delivery, also known as the hybrid closed loop therapy. But then there is an issue of higher cost in that particular technology. This is another which have been added. This is beta cell replacement therapy. This is the simplified overview of indication of beta cell replacement therapy in patients with type 1 diabetes. If you see, there are two groups, one with severe chronic kidney disease, another one is severe metabolic complications. So here you see those who have severe metabolic complications, they can go for either they have an intact kidney or an impaired kidney. If they have an intact kidney, they can go for pancreas transplantation alone or islet cell transplantation alone. But if they have impaired kidney, they have to go for simultaneous transplantation. That is both pancreas and kidney transplantation simultaneously, or islet cells and kidney transplantation simultaneously. But suppose there is CKD, severe diabetic CKD, and has to undergo a beta cell replacement therapy. In that case, if you have a living donor kidney, and then you can go for pancreas after the kidney or islet cell after the kidney. But if you have to go for simultaneous transplantation, it applies the same when what we discussed. It could be pancreas and kidney simultaneously transplanted, or islet cell and kidney transplanted simultaneously. So this again is new and been given as a chart, a good one, a good way of, rather I would say simplified way of putting it across. Now let's look to the third part, that is the comorbidity. Now this was already discussed, a multifactorial approach with a foundation, lipid modification and diabetic education, and then depending upon the different presence of the different comorbid condition, you have to plan out the therapy, and so that you can reduce the diabetic complications. So it has to be again a holistic approach or multifactorial approach to your patient of diabetes. Again, this is important, which have been added here, that a combination therapy with SGLT2 inhibitors and GLP-1 receptor agonists to address the risk of cardiovascular and kidney complication in type 2 diabetic patient with established atherosclerotic CVD or high CVD risk. So you can use a combination in these patients who have established atherosclerotic or a CVD risk. Emphasis on how the approach to management will differ in patients with newly onset diabetes or those who have existing diabetic medications. So again, the presentation of that individual is also important, which will define your management. So if he's a new onset diabetes, your management will be different, as I have shown in that particular individual. And those who have already existing diabetic medication, the approach will be a little different. And then this additional information has been given pertaining to bempedoic acid in combination therapy for LDL cholesterol lowering. Probably we in India are not using this molecule. Now, what does as far as diabetes and CKD is concerned, the whole idea should be to reduce the albuminuria by 30% if the CKD is plus more than 300 milligram urine albumin in order to slow the progression of CKD. So the objective is to reduce by 30%. Finerenone should be used in patients with albuminuric diabetic kidney disease to reduce the CKD progression and heart failure risk. A major emphasis to popularly categorize, as I said, should not only be defined by eGFR, but you should also measure the albuminuria along with the eGFR to define or categorize the CKD. So this has been emphasized here, that you need to consider both the parameters in order to define CKD or in order to categorize CKD. So these are the three new changes which are there in diabetes with CKD. What about the neuropathy, retinopathy, and foot care? They have clearly said there is no association between GLP-1 receptor treatment and retinopathy per se. So this was an issue with all the studies. Now they have clearly said there is nothing, excepting obviously the associated retinopathy and average HbA1c reduction. More emphasis on screening intervals and how they are based on the presence of specific risk factors for retinopathy onset and worsening. So that's very important. The emphasis happens to be on the screening intervals. So if there is presence of specific risk factor, you can modulate that interval. Then obviously they have strengthened the wording supporting previous recommendation of intravitreous injection of anti-VEGF, that is a vascular endothelial growth factor. And if that is not able to help, then macular focal or grid photocoagulation and intravitreal injection of corticosteroids are also reasonable treatments with persistent diabetic macular edema. And at times when you cannot give VEGF, then these could be the first line approach in this patient of macular edema. So this is again new, which has been added. If these modalities can be used if the anti-VEGF factor therapy cannot be used, or if it has not worked, then probably a persistent macular edema can, in those patients, this therapy can be used. A new section on cognitive capacity or impairment has been added with recommendation for monitoring and referral for formal assessment. Very much stressed upon, and this is a fact, particularly elderly, where this need to be taken into consideration, but almost in all patients of diabetes. Now, the last and the fourth important issue which they have tried to present in this standard of care is the glycemic targets and technology. So they have clearly said assess the glycemic status using a 14-day CGM assessment of time in range and GMI or A1C for use in clinical management and followed remotely. So a special stress has been put on the 14-day CGM assessment. The change of language is no more use of SMBG. Go for only blood glucose monitoring. So the next time when you are going to prescribe SMBG, don't go for it. You can write blood glucose monitoring. Time in range, time below range, time above range, they are the useful tool for directing the change in medical therapy. This has been stressed. They have already clearly said time in range is directly proportional to the risk of cardiovascular, microvascular complication and should be used for assessment of glycemic control. Emphasis that hypoglycemia is an urgent issue, plus guidance on triggers for hypoglycemia, avoidance, education, re-evaluation, adjustment of the treatment. But too much of emphasis on hypoglycemia has meant that you need to consider it's an urgent issue, number one. You need to advise what are the triggers for hypoglycemia. You have to guide accordingly. You have to avoid hypoglycemia. You have to educate the diabetic patient. You keep on re-evaluating and adjusting your treatment regimen so that you can bring the hypoglycemia to the lowest. So that's again very much emphasized in this particular standard of care. And these are the various the glycemic, this has been stressed upon. And these are the, sorry. And you can see the number of days CGM recommended is 14 days. The mean glucose should be less than 154. Variability target should be less than 36%. Time above range divided into two levels, level 1 and level 2. Level 2, if it is more than 250 milligrams, should be less than 5%. If it is 181 to 250, it should be less than 25%. If you see time in range should be more than 70%, that is between 70 to 180 milligram. And time below range should be less than 4% if the range is between 54 to 69. And it should be less than 1% if it is less than 54. So they have divided this hyperglycemia in level 1 and level 2, and level 2 similarly hypoglycemia, along with the proportion which should be there if you want a good glycemic control. Now, as far as the diabetes technology is concerned, they have highlighted the need for individualization of devices, recommendation, and utilization. The blood glucose monitoring needs to be provided to all who use CGM for calibration, verification of VG as needed, and to use it if CGM not available. So it's very important. Even if you're using a CGM, the blood glucose monitoring should be advocated so that you can actually match those two. And also important for calibration. Now, CGM recommendation combine real-time CGM or intermittently scanned CGM with different levels of evidence. The real-time CGM or intermittently scanned CGM should be offered for diabetic patient in adults with diabetes on multiple daily injections or continuous subcutaneous insulin infusion. So these patients who are on these two should be offered a real-time CGM or intermittently scanned CGM. And along with that, a special direction is also given that those who are using basal insulin, for them also recommendation of CGM is there. They should be offered for diabetes management in youth with type 1 diabetes on multiple daily injections on continuous subcutaneous insulin infusion who are capable of using the device safely. This has been stressed upon. Do not advocate giving a CGM or you are planning out this who cannot use the device safely. So along with that, insulin pens have been preferred and can be given depending on one need to be aware of the pen. The preferred the device obviously is pens. And use of technology, including the mobile apps, simulation tools, digital coaching and digital self-management support intervention have been incorporating, covering what has happened in last 3 years. These are very important modalities, and these technologies should be used as far as possible in all our diabetic patients. Obviously, another issues which have been raised is they have incorporated the COVID-19 factor as well, and the importance of management of NAFLD in diabetes management. So those are also in there, but I'm not included in these slides. So I will try to, I will end here. So I hope I have been able to do justice to the talk.
Thank you, Dr. Bijay Patni, for putting such a huge chapter in a nutshell and giving us an idea about the advancements. We have come a long way from the initial glucocentric ways to now patient-centric and holistic approach. And the way ADA 2020-22 has recommended on repeated counseling, use of maximum technology, and avoidance of hypoglycemia at all costs. And now the house is open for questions.
I think he has discussed it so nicely. I doubt there are any questions.
There's no need.
Yes, sir. Yes, sir.
Okay. Then what I'll do is I will close this session.
Yeah.
Once more, I request Professor Dr. A.N. Rai to. Yeah, somebody has a question. Please go ahead. Please go ahead. Sorry.
Sir, this is Dr. Harsh. Can I?
Yeah, please.
Please go ahead.
Please go ahead.
Sir, as far as the latest recommendation, which is there in the ADA, one thing which I would like to emphasize or would like to know from you that as a nephrologist, we normally see patients who are having GFR normally less than 45 or less than 30. So the point is, Filrinone is not available in the country as of now because I have no idea about that. Number two, the biggest problem with RAS inhibition has been hyperkalemia. So the drugs which are left to us for preventing the complication of diabetic nephropathy is SGLT2 and GLP-1 analogs. So my question is, in your very first case which you mentioned, the first case was that he had a cardiovascular event. Similarly, we had a lot of patients who are going to have renal, dysfunction. So for that, the very first case, what could have been done to prevent his cardiovascular complication right from the onset? Number one. And number two, what could have been done to prevent the onset of diabetic nephropathy? Third comment is the use of anti-VEGF and worsening of proteinuria. So we are seeing a lot of patients, and there are a lot of literature where they have suggested that anti-VEGF is causing a lot of podocytopathies. So now we need to relook at the way in which we are managing diabetic retinopathy in a patient with diabetic nephropathy.
Right. And the first thing first, obviously what we tried to address in these cases was how to use this algorithm. That was the whole idea. It's not that it was a real case where it has progressed in that way. First thing first, you should realize if we take this algorithm as the standard of care, then the individual on presentation didn't had any issues excepting the HbA1c of 7.2 and a little bit of prandial of, I think, 170 or something like that. No other factors were there. If you go to the algorithm once again, then probably it is clearly shared the lifestyle and metformin should be the ideal drug for this individual. So here we are not addressing the issue that how to prevent cardiovascular or CKD in this individual in a later life. What is more important, if you go a slide earlier, what I said, how to address the plan out a therapy and thereafter prevent everything. If you have a proper follow-up in the case and you have a shared decision making in management, and you can follow up this and then keep on advocating whatever changes you wish to do over the time, then that is the best way. But that usually doesn't happen practically. Let me tell you, we lose the patient for consultation or follow-up, and that is what happened in this case. Though it is hypothetical, but we have lost it. And the patient ultimately came with AMI and high blood pressure. What are you left with? You are left only with two drugs, correct? You have already said that GLP-1 or SGL2. If you look at the glycemic parameter, whichever suits you, whichever is advocated for this gentleman, you can use it. Now CKD, before that, his eGFR was reasonably okay. And as and when he developed the microalbuminuria and the eGFR less, obviously the first drug of choice happens to be the SGL2 inhibitor. And we don't have the other molecule, as you already know about it, we don't have in India. So there's no point. It is there in the standard of care. So we have to mention it. So prevention can only be that if you have a regular follow-ups and you have a regular monitoring system, which probably we lack. And to be very truthful, it is very, very difficult in our patient at least. But if you can really, I have patients for 25 years, which we have been saying it, and patient has not developed a CKD yet. So that can also happen. So it is not that you have to interject at the very first time when your diagnosis and case to prevent a CKD. All we need to take care is to monitor the blood sugars and keep the blood sugar under control and take off all other factors which could lead to deterioration in the or it could increase the comorbidities.
I fully agree. Sorry to interrupt, sir. I fully agree with you. I was trying to highlight the dilemma and the agony of a nephrologist in treating diabetic kidney disease. Number one. Number two very important points which I want to highlight here is that you should, as you rightly said, normally we miss to measure urine proteins and UACR, which is very, very important because these are the markers which you pick before the creatinine rises. Number two, whenever we are prescribing somebody on RAS, one should completely bear in his mind that we need to monitor potassium because we have seen patients who are being on RAS inhibitors, who are being on, torsemide and spironolactone combination, presenting with creatinine 1 with CHB and heart blocks. I mean, with bradycardias. So these 2 points as a nephrologist, which I feel is worth mentioning.
Absolutely.
Can I make a comment here?
Yeah, please go ahead.
I just like to make a comment here.
Please, sir.
Medicine is a science which is full of probabilities and uncertainties. Just to give you an analog, we say that whenever you are driving a car, please wear a seat belt, so that if you happen to have an accident, the chances of your getting injured fatally is very less. But that does not mean that if you don't wear a seat belt, you will not go to accident and then nothing will happen. Some patients with seat belt have died. So what I want to say exactly is, when we start treating diabetes in the early stages, we always advise that if you can get a tight glycemic control within the first 5 years, it is very unlikely, again probability, that you will not develop a complication. But unfortunately, we have seen that despite glycemic control, there are people who have developed complications like nephropathy, and there are people with uncontrolled blood sugar who have not developed, as Patni said, that 25 years, no CKD. Now the question is, these are very gray areas. We don't know what is happening, how much genetics is involved here. So see, our aim is, you have to have an holistic approach right from day one. You have to assess the patient absolutely. And I think urine for albumin-creatinine ratio is one of the investigations which should be done from day one. There is
Yes.
no doubt about it. There is
sir, probably we are very lucky in having these two molecules, SGLT2 inhibitor and GLP-1 receptor agonist, in this area of cardio-renal protection, along with the anti-hyperglycemic effect. And one thing very important, which Dr. Bijay Patni pointed out, that GLP-1 receptor agonists have been exonerated of the side effect of retinopathy. And ADA has recommended that if glycosylated hemoglobin is reduced all of a sudden, then the retinopathy results. And GLP-1 receptor agonists cannot be blamed for that.
No, sir, I beg to disagree here, except there is a caveat here. The GLP-1 receptor agonist in general, but semaglutide, especially injectable, is still shown that it can cause retinopathy. And they have not been able to explain why. Because
okay, sir.
The notorious drug was only injectable semaglutide. No other.
No. Again, there is a reason behind that. Again, they showed that it was a rapid decrease in the HbA1c, which was responsible for this.
That's one of the hypotheses.
Yeah.
That's one
maybe, sir, semaglutide was more effective than other GLP-1 receptor agonists.
Clearly,
and so possibly retinopathy was more.
Bijay Patni, just to give you an analog, Khaita caused a lot of amputations. Whether it really caused or not, we don't know, but it has earned a bad name. As simple as that.
The same thing happened with sexagliptin, sir.
इसी तरह semaglutide बदनाम हो गया. अब
Glitagon also got blamed for carcinogenic effects.
Not for PIO.
PIO.
Oh, that a cancer that was again, and that's a different story. I don't want to bring it up.
I think one issue with Dr. Harshvardhan raised was the anti-VEGF therapy causing issues with the kidneys. I mean, if you just take the population who has received it and then take those, there is a definite chances of that happening because there is already studies which is pointed towards them. But just the number of patients who have undertaken this therapy and thereafter developing this is very, very low in clinics, I would say, in clinics. But definitely the studies are pointed towards them. That is why they have advocated these two therapy as a replacement for if you are unable to use that VEGF, you can use these two therapy for macular edema.
Sir, I've already submitted a paper for ethical clearance. We are looking into it, and we are recruiting patients to, look into this particular complication.
Yes.
So, if no more question, we would like to thank Dr. Bijay Patni and hand over to Dr. Anil Virmani sir, and then to Dr. J.K. Lohani to wind up.
Thank you, Dr. Khaita and Dr. Jha for chairing this session, and both the speakers did a wonderful job. Before I hand over to Dr. Lohani, again, I would request Professor A.N. Rai to give his final comments, sir.
Thank you, Dr. Virmani. I think both the speakers have spoken very excellent presentation. The presentation was very good, and it is crystal clear from both the speakers. I think the neuropathy, it was a painful neuropathy we are all having, and we always see the patient, but we never look for the food. Always, all diabetic patients should be looked for. Foot care should be there. So, if you want to prevent diabetic neuropathy, blood sugar control and care of foot is there. But in spite of all these things, we do have painful neuropathy, and the drugs have. Pregabalin is the one which we find better. But as Dr. Jha said, if some of the patients do not tolerate pregabalin. If you give, they complain of dizziness, vomiting, and all these things. That is a problem. But the second drug, which personally I feel is amitriptyline or tricycline antidepressant, it is, I found combination of pregabalin and tricycline antidepressant, they are really very good. Coming to the talk of Dr. Patni, it was a very elaborate talk. He has presented a hypothetical case, but he discussed what is the latest guideline says that if you non-complicated case, go with the metformin. and must you go for not glucose centric but patient centric. And if the patient has complication, cardiovascular complication, the drug of choice is GLP analog or SGLT2 inhibitor. But if the patient has got heart failure or CKD, SGLT2 inhibitor are the drug of choice. I think with this we conclude. I think we should conclude. We are already very late, and hand over mic to Dr. Virmani.
Thank you, sir, for your expert comments. I will just give the last 4 messages of today's deliberations. I think we have done a wonderful job today with the speakers. We have learned, number one, that diabetes is no longer a metabolic and vascular disease. It is primarily a liver disease. The fat in the liver and which is thrown into the pancreas is the main culprit. Then we also learned that there are a lot of gender inequalities, and equity is very important among the genders. Then third thing we learned was today that painful peripheral neuropathy is one of the most challenging clinical conditions to treat for any clinicians. And lastly, as Dr. Patni very nicely elaborated, that today in 2022, we need to have a holistic, patient-centered approach, teamwork, where patient is the captain of the team, not the doctor. And with these few words, I once again thank Dr. K.K. Lohani for giving me this wonderful opportunity. And over to you, my dear friend, who also happens to be my class fellow in MD Medicine. Over to you, Dr. Lohani.
Thank you, Dr. Virmani, for conducting this session so nicely and for arranging this CME so sincerely. I think we are coming to the end of this